So I think I would be really grateful to ask Martin, who's the first speaker, to join me, and we'll get going. So welcome to everybody. And just as a last thing, if you're an exhibitor, please do come through and join seats here. There are plenty of seats. So please feel free to come through and join us down in the main room. Martin.
Well, thanks very much, David, and thank you, everybody, for asking me to come and talk to you today. What I want to do is, first of all, acknowledge what amazing work you all did during the pandemic. I think we cannot underestimate the amount of commitment that was shown by the social care sector during that very traumatic first 2 phases of the pandemic. And I really hope that this will be a foundation, and the legacy of that pandemic will be a different approach to social care, and also greater respect for the people who work in social care and support people who need care and support. So I just think we should acknowledge the enormous contribution that you all made during the pandemic. I think also that, though, the pandemic has left us in a bit of a fragile position, and that is why we are desperate for a reform agenda that will be something that can be a foundation for the future. And I do think that we have exhausted staff teams, you know, the amount of things that people went through, and I think many people are in what might be described as post-traumatic stress after what they went through. And I think we've got to use that as a platform to say this has to change and improve in the future. Now, everybody talks about the reform agenda, and certainly, you know, I remember giving speeches, and I remember giving speeches to this conference when I talked about how Tony Blair had promised reform in 1998, and we'd had a succession of prime ministers, all of whom had promised reform, and none of whom delivered it. So it was with great and eager anticipation that we looked forward to the fact that the government was going to bring forward a reform agenda, and we hoped that that would be a new beginning for social care. Very sadly, this did not materialise in terms of where we are. So this reform agenda, which was billed as being the future of social care, was in effect a recovery plan for the NHS. So the government put into place the levy on everybody's salary, and everybody thought this was going to deliver money for social care. Well, it delivered 39 billion, and 35 billion of it is going into the NHS for 3 years. This is leaving us with very little money to transform social care, and particularly with very little money to build back better after the pandemic. There was also a commitment to taking 500 million for workforce development. So already the money that was allocated, suddenly we've taken 500 million out of it in order to look at workforce issues. Now that equates to about £312.50 per employee over 3 years. That is not going to transform the employment position, and it's not going to make enough money available to start paying people what they are certainly worth. And I absolutely think we have got to get away from seeing social care as a job. Social care is a profession, and it is highly complex and highly skilled. And we should be rewarding and recognising and training the people in our sector and respecting them as the professionals that they are. Well, certainly 500 million is not going to in any way move us towards that. My hope is that some of it will be used to develop some clear skills and competency frameworks and some portable qualifications, because I do want people to understand that if you come into social care, you will be in a career that you can progress. But that does require us to have some really clear routes to development and progression within our sector. There was also a commitment by the Prime Minister generally in the economy to move towards what he described as a high-skilled, high-paid sector. Well, I think there is no better place for him to start than in social care. And he could have made social care his flagship for this high-wage, high-skilled economy. But sadly, when you see what's been allocated, that is not going to happen. There is also a lot of talk about quality in the reform agenda, but there is little or no understanding of what quality means. So the talk about quality is not underpinned by clear quality frameworks or outcome measures or things that will be absolutely clearly tangible when it comes to, for example, us challenging commissioners as to whether or not they're commissioning quality. That, again, I think was a really big omission in this reform agenda. I think also there is a real problem about the way in which everybody has talked about reform, but the majority of this agenda is about self-funders who are older people and in residential care. Now, social care is much broader than that. This reform agenda says very little to services that support people with learning disabilities and autism. It says very little for people who might be disabled but younger adults. And so what we have got is something that has focused on what individuals might have to contribute, but very little about a new beginning for social care. I also think there have been some what I consider to be quite mixed messages. So the headlines about you won't need to pay more than £86,000 for your social care does not really give people an understanding of the reality. So, for example, if you're in residential care, you will have to be looking at things like the accommodation costs. I think people think that the 86,000 will be reached when the services they're getting have reached 86,000, but of course you need a local authority assessment, and if we don't get a proper costs of care exercise, the local authority funding rate, which will be much lower than the true costs of care, will not be the thing that people move towards their 86,000. It'll be the LA funding rate, not the true costs of care, that move you in that direction. So again, a lot of expectations have been raised in the minds of the public that are not going to be fulfilled. I also want to say I'm extremely concerned about the capacity of local authorities to be able to administer this new change. When you look at the numbers of people that they're having to do assessments for, that in itself is an enormous logistical challenge. But what hasn't been taken account of, in my view, is the number of people who will challenge the assessment. They will say, I don't agree with this, I want to go through a challenge process. And this will create another enormous bureaucratic problem. So I think this is going to be a major challenge. And for me, what I hoped would be something that was going to transform social care, because of the piecemeal way it's been done, because of the fact that it is not underpinned by enough money, we are all going to struggle to make this work. I also have a real concern about a commitment the Prime Minister made when he said that he would not allow self-funders to have to subsidise publicly funded clients. And there is an element of the Care Act, 18.3, which allows local authorities to take on the role of commissioning the care for self-funders. Now, what this could mean is that people will go to the local authority. You as providers will not know whether they're a self-funder or a local authority-funded person. The local authority will have a designated rate, and they will try and place this person at that rate. So the final impact of this could be to suck more money out of the system than it puts in. I talked at the start of this presentation about how this was, in effect, a missed opportunity. And it is so disappointing that after all these years of waiting, we have not got that comprehensive revisioning of social care that we were all expecting. And I think, I wanted to start with a new vision for social care. I wanted people to understand what is delivered by social care, how it transforms people's lives, how it enables them to live well. And that should be our absolute primary purpose in this sector. And it would be really great if the government revisioned social care with that as its objective. We also need some very clear long-term and sustainable funding within our sector. There are few sectors in any economy in the world which they know through the demographics are going to grow and develop, but the government fails to deliver the long-term funding solution. And there is also a problem in that the government, and I have to say the general public, is absolutely obsessed with the NHS. So whenever there is more money available, it tends to go into the NHS. But that is not the reality of 21st century Britain. The reality is not that you diagnose somebody, you send them to hospital and they come out cured. The reality of the 21st century is how do people with long-term conditions live good lives? And it is social care that delivers that, not the NHS. And I do think we have got to wean ourselves off an obsession with an institution and start thinking about the people who are supported and the outcomes they want to achieve. Because for me, it doesn't matter whether it's public sector, whether it's voluntary sector, whether it's private sector. All the focus should be on the person who receives the service, what it can deliver to give them a good quality life. I also am very disappointed in this notion of what they're not going to do around skills and the workforce. You know, you will all know that the workforce is our biggest asset, but you will also know that it's always been a challenge, but now it is at crisis point. Trying to recruit and retain our colleagues is extremely difficult when we don't have either a proper approach to a career pathway or the money to pay them what they are worth. And I really think we have got to reappraise the whole issue of how we think about the workforce, how we attract them. But I would also say, and it's a tough message for hard-pressed employers, we as employers also need to get more creative in how we, first of all, look for new staff, but also how we develop more flexible approaches to work that will invite people to join our sector. Because many people now want greater work-life balance. Many people want shorter shifts to be able to accommodate other parts of their lives, often other caring responsibilities. So I do think it is our challenge to think about how we can do what is in our power to make this more attractive as a place to work. We also, I think, need a clear intermediate care strategy. You know, Jane Townson and I go to many meetings at the Department of Health and Social Care, and they talk endlessly about how hospitals are clogged and blocked. And they also try sometimes to blame our sector for that, saying there are not enough places or there are not enough home care hours to be able to move people out of hospital. Well, partly that's because we're underfunded, we're under-recognised, and we are not given the status that we deserve in the role that people pursue when they come out of hospital and the support we give them. So I think we need a very clear intermediate care strategy, and it's always about bed blocking in the NHS when people talk about it, so I want the money to come from the NHS. I want proper tariffs that people know they will get. I want them to be pretty national, probably some slight variations around localities, but not much, but also time limited, so that people know that this is part of a different process. And if we move towards that, then I think we will get a really clear intermediate care strategy, and then people being enabled to move to the next level of support they need, and particularly maintaining their independence for as long as possible. Because I think that's what citizens really want, and I know that's what social care delivers. And I think what we haven't got is an understanding of that in both politics or indeed in the Department of Health and Social Care. We've also, as a sector, got to embrace technology. You know, it's very interesting that we're having this problem around the workforce, but we need to take a step back and say, are we doing everything we can to be as efficient and as effective as possible? What I would really like the government to do is set aside a quite significant social care technology enablement fund. And yes, there needs to be a whole raft of things that are about, how you rota and how you deliver the care plans, etc. But you also need, in my view, a very, very clear strategy on how we get innovation and how we use technology to innovate and develop our sector. And what we need is some money that will seed corn some of that. I would also say to care providers, I really wish you would get more connected to technology providers, because if you come up with a challenge, they usually can come up with a solution. And I really would like the government to create some forums where people could come together, could identify challenges, and then say to technology providers, what can you do to help us deliver an outcome, and particularly to deliver it more efficiently? I should also say, I talked about the differences in funding and the vision for social care in the reform agenda. And I particularly said that older people who are paying for their care seems to be the focus. But I also want to say, I think that our system is institutionally ageist. And if you are an older person, you are not given the same options and choices that you are if you're a younger person in many situations. So every time I hear an adult services director say to me, everybody wants to live in their own home, I say to them, everybody can live in their own home, but what you have to do is commission 24-hour care, 5-6 people round the clock to enable that to happen. But they never want to do that, of course. What they want to do is commission everything to a price. So if you go with a younger person who may have autism or a learning disability, you will work out what they need and there will be a bespoke package for them. Go if you're a person with advanced dementia, perhaps some challenging behaviours. The local authority will expect a bespoke care package, but that it will expect that package on, £450 a week or whatever it is they pay. And that has got to be challenged, I think. I'm very disappointed that some of the large charities that support older people have not challenged this. Age is a protected characteristic under the Equality and Human Rights Act, and yet older people are getting a bad deal out of the system. And I'd be interested to hear what Mei-Ling thinks about that. But I do think we should think about how can we use the law to move the agenda forward. I think also, finally, we need to have a culture change programme right across the NHS and indeed in the minds of the public sector. We need them to understand this is not about organisations or processes. This is about people and about outcomes. And I have to say, during the pandemic, I found it completely ridiculous that we had a Prime Minister who would stand behind a lectern and say, stay at home, protect the NHS, save lives. The NHS is not an end in itself. It is there to protect us. It'd be like Barclays Bank saying, don't spend your money, leave it in our vaults, protect our investment. I mean, it's ridiculous. And so we do need to have a bit of a mindset change in how we view these organisations and remind ourselves that if we're going to reform the agenda, we reform it on the basis of what people want and need, not what organisations want and need. I want to finish by saying, despite the doom and gloom, despite all the things that I've said during this presentation about the challenges within this reform agenda, what I think is the best hope for the future is the people who work in social care. You are dynamic, creative, innovative, and I mentioned that we had waited 24 years since Tony Blair for reform. And during that time, what we did was we grasped the agenda. We did it for ourselves. We didn't wait for government to come up and deliver. We delivered sometimes in the worst of all possible circumstances. And I think that's what we have to do now. We have to accept the reform agenda is not what we want it to be. But we have to say, how do we make the best of it? How do we deliver sustainable services? How do we deliver high-quality outcomes for people who need our support? Thank you.
Thank you, Martin. Lots of challenges there in your presentation. So one of the challenges from me to you is that one of the things that care associations can do is be part and parcel of that challenge. And we can be there challenging with you, for you. Sometimes we challenge you too. But more often than not, our job is to challenge around the piece on your behalf. So please do think very carefully about what you want us to be doing at the end of this session, and not this session, but today. So start writing down some things that you want Care and Support West to be doing, and join us in that challenge. So thank you for that. I was a bit late giving Martin this, which is the clicker for the slides. Is it the white one? No, it's the next. Where it says next would be a clue, wouldn't it? Yeah. So, Mei-Ling, I'm giving you the clicker.
Thank you.
Welcome.
It's only got 3 buttons. Still feels like a challenge sometimes. Hi, everybody. I'm Mei-Ling Huang. I'm from RWK Goodman. You knew us formerly as Royds Withy King. I'm here today with my colleagues James Sage and Chris Amies from our employment team, so come say hi to us. It's really great to see you all in person today. I hope that we'll have a chance to have some interaction, because I think that's often, what's missing from the Zoom calls. Fixing social care locally, it's a really, really difficult thing to do. Why is that? Well, I think it's probably because there's so much that's beyond our control that is not local, right? Martin talked a lot about what's wrong in social care. What are the big things that are wrong? I think, we all know what they are, so I'll just sort of quickly list them out. We've got lack of funding, right? Staffing shortages, low wages goes along with lack of funding, lack of a career development pathway, lack of parity with the NHS. Here we go, here's the slide. A lack of understanding by the public about how our sector works, and by government about how our sector works. We've got regulation that can be very reactive. We've got safeguarding systems that can be very reactive. And we've got reactivity versus proactivity generally. And I don't know if you can see my slide, but if you add it all up, what does it add up to? It adds up to a lack of sustainability built into the sector. So everybody's fighting fires all the time, just trying to keep the system going. And that holds true for managers, for providers, for commissioners, for safeguarding officers, for CQC probably as well. And I think if we're going to fix social care, what we need to do is to start to build sustainability into the system. So what can you do at the local level to do something about it? I think, first of all, we need to understand what's going on above our heads at the national level, and Martin's insights into that are very informative. And then I think we need to probably, number 2, refocus the conversation on sustainability. So what's going on at the national level? Martin's talked about this already. We know that the government has said it will fix social care. Boris has revived the possibility of a cap on care costs, which previous governments kicked into the long grass because it was too hard. That was probably 2015, 16, something like that. This has been revived again, and we're now starting a cost of care exercise on the local level. You may also have heard that our friend Jacob Rees-Mogg, who's the, let me get this right, the Minister of State for Brexit Opportunities and Government Efficiency, has been tasked with reviewing the effectiveness and efficiency of arm's length bodies, or ALBs. The ALBs that he's reviewing include CQC, NHS England, NICE, and the UK Health Security Agency. The press is reporting that his Public Bodies Review program will consider whether ALBs should be abolished or retained. They love a headline. whether they should continue to deliver all their functions, and whether they have an effective relationship with their relevant departments in government. And he's also, Jacob, reported to be tasked with trying to identify savings of at least 5% from the operations of these bodies that he's going to put under the microscope. So if I were NHS England or CQC and I had Jacob Rees-Mogg reviewing my effectiveness and efficiency, I think I would be worried. I probably shouldn't make political statements, but I doubt very much that Mr. Rees-Mogg either knows or actually cares very much about the effective running of the NHS or CQC. I'd hazard a guess that he will put politics before policy in this regard. So unfortunately, whatever happens there's likely to be a knock-on effect for all of you. What else is happening at national level? Well, CQC are making some changes in the way they inspect and regulate, and change is always scary, but I think potentially we have the potential here to improve a bit on what we have right now. So currently we have a system under which CQC is mostly inspecting in response to risk. In other words, we've got a reactive system. CQC hears something concerning and they go and inspect to see what's wrong. They now say that they're going to refocus attention on the service being received by individuals. And I think that that must be a good thing to do, to refocus on people again, because that is something that definitely got lost during the pandemic when we were all running around worrying all the time about infection prevention and control. Not that that was, misplaced. What about commissioning? Martin has said, and I think I agree, that the commissioning system is broken nationwide. I don't need to tell you that, though. You already know that. We have, in elderly care, we've got delayed transfers of care. In the LD sector, if people's needs are no longer met at a particular service, it's really, really hard for them to move because there's nowhere for them to move to normally, and it takes months to transfer anybody between services. So that's the big national picture. Let's turn to the question that's being posed to us today. What can we do on a local level to fix social care? And David, I have to hand it to you. This is a doozy of a question. Very difficult question. I don't have all the answers, but I have some suggestions about what we should maybe be aiming for, which is being lost in this maelstrom of activity going on above our heads at national level. And I think what's missing in all this frenzy is the focus on sustainability, as I already said. So we need to build sustainability into the system, but how? What are the big ticket items? Well, funding. Funding needs to be sufficient to help fix problems we talked about earlier, and it needs to be sufficient to help address the staffing problem. Workforce. The workforce needs to be bigger and better supported. People need to see a future for themselves in the sector. They need career pathways and support that make it worth their while to stay in the sector. And in terms of regulation and safeguarding and that sort of thing, I think we need a system that doesn't just knock you down, but also helps to pick you back up. We need safeguarding and regulatory systems that build resilience into services. In addition to criticizing, they need to help support you. So, what can you do about it? I think that the answer is that you here on the ground at local level can provide leadership. The great thing about the private sector and the voluntary sector is that you have some freedom to maneuver. You can innovate. The way you do business is up to you to a certain degree. So my suggestions, which are threefold, all relate to taking steps to build up your local system. First of all, focus on sustainability. You can't control Jacob Rees-Mogg and what he says about CQC and how they're doing their job, but you can think about the choices you make and try to develop your business plans in a way that makes your business more sustainable in the medium to long term. So that may mean saying no to things. And with apologies, I don't know if the people from Bristol City Council are here yet, but we've seen this work locally before. And I can recall a time not that long ago when Bristol City Council tried to push fees down by going to a tendering system. Do you all remember that? Yeah. My own opinion is that while they were looking for cost savings, this was really counterproductive because it wasn't going to be a sustainable option for the market. In the event, a lot of you did not tender for the work, and Bristol City Council ended up having to pay more than they wanted in fees, and instead of going down, the fees went up, right? This was simple supply and demand at work. Providers said no to lower fees, and commissioners had to rethink what they were doing. Second, Focus on your people. The staffing crisis has had just about every provider I know on their knees, not to mention the poor managers who've had to spend all their time running around trying to get enough staff to fill the rota. You can't magic up extra funding from thin air, but you can focus on your people. So in my experience, if you invest in people and empower them, they will usually give you their all. And we've seen this already throughout the pandemic period, isn't it? This is something within your control, and you can start small. So to take an example, one of you here recently decided to do something for your team to bolster their feeling of team spirit and unity. They took their team on a team building exercise, and they went out in Land Rovers and drove around on an off-road course. What do you get out of a day like that? Well, I'd say you get a feeling of unity, and you also get a sense of empowerment and also fun, right? So we all watch Top Gear. Jezza and his pals, they go out and they do something crazy. But to actually do it yourself would be brilliant. I think, how could you help but feel enthusiastic, empowered, part of the gang if you go and do something like that? Let me give you another example. This one's a bit bigger. I know a provider in Surrey who runs a group of outstanding nursing homes. And like most nursing providers, they were not able to get nurses for love nor money. What did they do? Well, they started to recruit nurses out of Kerala in India, and that was fine as far as it went. But it was still expensive and time-consuming. So instead of stopping there, they decided to start their own college in Kerala. And they now train their own nurses for the social care sector. And they've got a steady stream of nurses coming through, and they never have to use agency. They can assess the candidates throughout their coursework and then pick the cream of the crop on graduation day. So this provider thought big, like really big, right? But they haven't looked back. They haven't looked back for a second, and they fixed their own nurse staffing problem. So I guess what I'm saying is that we here on the ground locally, we need to ask ourselves what we can do to focus on building a better sector. And in the myriad of decisions that face us about this stuff, we need to ask, how do our decisions affect sustainability? How can we fix the problems ourselves? Number 3, have honest conversations that refocus the minds of others on sustainability. Some of you have started participating in a cost of care exercise, no doubt, or you're about to. And when the results of that come back, I fully expect that you will be disappointed. I just cannot see how, with local authority budgets as they are now, the answer to the question, what is a fair cost of care, is going to be anything like the rate that it would actually take for both local authorities and private funders to pay the same fee and for the system to become sustainable. It just ain't gonna happen. The current system's limping along, it's broken, it can't carry on like this. So I think it's up to you and up to us collectively to show leadership and to say no, and to refocus the conversation on sustainability and fixing social care at the local level. This will require reaching out to your DASC and having an honest conversation about that. It will require you to educate your MPs about that and keep them informed. What about other aspects of the system, CQC and safeguarding? I mean, I think the trouble with a risk-based approach is that when CQC or safeguarding hear that you have a complaint or whistleblowing or whatever, they don't necessarily understand where you're coming from. Nobody does a bad job on purpose. I've been working in this sector for around 16 years or so, and one of the things I love about it is the people. So you guys, you're all a kind lot, you're a generous lot, and you make it your life's work to look after people who others maybe would just rather forget about. And I think that the spirit of altruism that drives this sector gets forgotten, particularly when we're talking about safeguarding or inspections. And unfortunately, rather than starting from the understanding that everybody wants the best for people, the tone immediately becomes punitive. Therefore, I think it's up to you and us to establish your credibility and build bridges towards those who are going to judge you in this context. And I can tell you from experience, it's a lot easier to defend yourself in a safeguarding if you've established your reputation as a good provider before something goes wrong. Safeguarding issues will happen. They are an occupational hazard. You need the regulator and the local authority and the CCG to know that you are credible and responsible and have people's best interests at heart before something goes wrong. So you may be thinking to yourself, you know, all this is fine and well for you to say. It's all very lofty and, you know, it's just too bloody hard. And I agree with you, it is hard. This is very difficult stuff. But what we have to do, I think, is start with a few small steps. So today is a chance to start that by just asking yourselves a few questions. What is one thing I can do to build up my staff team? What is one thing I can do to say to commissioners, what was one thing I could say to commissioners to make our relationship more positive? What is one thing I can do to build a bridge to my CQC inspector and explain to them how great my service is? What is one thing I can do to get social care the place it deserves in my ICS? I think it's crystal clear that we're lacking government leadership at a national level, and that's why it's up to us at a local level to take the lead and refocus the conversation on sustainability. There are a lot of us here, and if we all can work together, I think we can make a start on fixing social care locally. Thank you.
Thanks very much, May. Been a lot of talk about the cost of care, both between Martin and May. It started off, you will recall, as an exercise on the fair cost of care. And then not a lot later, the word fair got taken out. I just wanted to draw your attention. You'll see on your table that there's this report, Service Costings Considerations. Just wanted to let you know, just as a piece of information, that Care and Support West is working with, certainly with all three of the local authorities this end, so North Somerset, South Gloss and Bristol, in relation to that cost of care exercise. And what we've been saying to them, what I've been saying to them is this, that the toolkits that they're using will only capture data for 21-22. And what we've been saying in this document and elsewhere is that if you want to know about the cost of care, you not only need to do that, but you need to look forward, which is kind of what May and Martin have been saying. But I just wanted to let you know that that message is loud and clear with each of the three local authorities, because I make it that way. But there's more you can do and more you can be saying to your commissioners about that. So reminding them that the cost of care, the fair cost of care, is about not just now, 21-22, but also 23, 24, 25. So just to remind you of that. The piece of the exercise now is for you to have a chat around your tables, both about the information that Martin shared with us and May has shared with us, and to come up with, if you have any, questions or questions of clarity or things like that. So we're going to have 10 minutes or so for you to be talking around your tables, and then we're going to do a quick Q&A session. Holly and I will wander around with a microphone, and you can be asking your questions. And once again, please, it's an opportunity for you to be writing down the things that you think your care association can do alongside you. May gave you a big list of what you can do, what things you can be thinking about. It may be that we can help you in those. So let us know that. So yes, conversations around your tables. If you're only a very neat and small table, you might want to join another neat and small table. It's up to you. I guess if there's only one of you, then you should, but there are some pairs here. So please do join other tables and have your chat. Thank you. So hopefully your questions are forming, and Holly and I are ready to rush around to your table, and Martin and May are ready to answer questions or take points of clarity. So who wants to start? Hand in the air, please. No hands in air. Surely there must be a question or a point of clarity. Ah, thank you.
Want me to give my name first?
Yes, please, yes. It's on.
Hi, Mike Sater, Osborne Care. Two very interesting and thought-provoking presentations. My question is to Professor Martin Green. Why do you think the devolved administrations seem to be doing so much better for social care? And if you agree with that statement, what can we do about it in England? Thank you.
Thank you.
Well, what a great question, first of all. I think that's really interesting. But I also think we should unpick what is actually going on in some of the devolved administrations from what is going, with what people present as going on. So Jane and I were recently at a Five Nations forum, which we go to quite regularly with our colleagues in Scotland, Wales, Northern Ireland, and indeed the Republic of Ireland. And one of the things that we found was, in Scotland, particularly in the post-COVID, era, Scottish care services are going through absolutely horrendous times with scrutiny and police investigations on everybody who died in their care services during the pandemic, etc. Some of the reality of integrated services. So, for example, we hear that there's integrated services in Northern Ireland, and Northern Ireland is completely and utterly in a state of flux because they've got no government, the money is not being allocated. We also hear from Scotland that the suggestion that they've got a much more integrated system isn't really true when you start asking people who use services. Similarly, some of the regulatory things have worked better in some parts of the UK as opposed to others. So it's a really interesting question, but I think it's one of those questions where you've got to really unpick it and you've got to listen to the real voices rather than just the headlines, because often politicians will tell you that they're doing things and everybody thinks it must be better. There is also an issue, I think, which in places like Scotland and Wales, there are fewer people who need the support, so the scale of it is smaller, and that's easier to manage sometimes. And I think we don't acknowledge that often. So I think it's a more complex picture than you would necessarily think it is, and Jane and I certainly saw that when we were at the Five Nations. But what I think, the point you make, though, is a really interesting one. What we should be doing is saying, when we identify things that are working better in Scotland or Wales or Northern Ireland, we should be then saying, how do we implement them here? How do we learn from each other so that with every different attempt to change the system, we get better rather than just have change for its own sake?
Thank you, Martin. Another question? Who's next? And there was me going round, down there, by all means.
Hi, David. Sarah and I work in the training hub and as social care nurse ambassadors, and I think we would like to know from providers what we can do to help you with health-related training. And I think the question to May is about that sustainability. How do we develop that with a shared vision between health and social care? People live in their homes and not necessarily thinking about health all the time, but I think to keep people well and the ageing well, Des that's going with Department of Health and Social Care, I think we need to work together more, and I think that partnership working needs to happen. So how do you think we should do that?
In terms of partnership working between health and social care, that's a great question. It feels like when social care is even let into the room to have that discussion with their health colleagues, a lot of times they just aren't listened to and get ignored, and that's part of the problem, is sort of getting people's attention. And so first of all, you've got to get their attention, and that's not necessarily an easy thing to do, But I think if you can help to solve some of the problems, you know, I think Martin and Jane, we were just talking and mentioning about health colleagues complaining about a lack of home care, for example, when people come out of hospital and things like that. If you can help to suggest some ways to solve the problems that they are facing, probably you will increase your credibility with them, because I think there's a, you know, it's not correct to downplay the importance of social care, but that's what happens. So you've got to establish your own credibility and your own, you know, engender a sense of respect for our sector with the within the healthcare sector, by probably starting to help them solve some of the problems that they're facing. And you know, there is a chance probably to do this with ICSs, but everybody needs to get in there and make sure that we have a seat at the table from the get-go, right? Which is not easy. That's potentially something that care associations are working on. I don't know where David's gone. Oh, there you are, sorry. You know, I know that we have that discussion with care associations and trying to get in there and make sure that you have a seat locally on the ICS, and that's probably a way to start. But you know, focusing on what's important to them and saying, well, that's, you know, we can help you with that. That's part of our issue as well. And you know, Martin and Jane have both suggested, I think, that that's a way potentially to get some additional funding into the social care sector as well, is to help the health problems by asking for some of their funding to help solve their problems, but you would do some of the legwork for them.
Thank you, May. Moving on from that, any other questions around at the moment? I don't see any. Oh, down there, yes, please.
Hi, it's not a question, more of an observation or of thoughts from what I heard. I'm a team manager within a council, South Gloss Council, and I deliver assistive technology services, and that's about using commercial and bespoke technology to delay, prevent and reduce the need for care and support. And I was interested to hear your comment that we have to adopt technologies and integrate technologies in care provision. And it's a massive challenge and it's a huge culture change. And I need you all to think about that, because we're all happy to use technology in our own day-to-day lives. We do it without thinking. But when it comes to using technologies to deliver care and support, we all become incredible. The fear is phenomenal. Okay, people become risk averse. And they become very frightened about the outcomes of using technologies instead of people. So have a think about that and think about how maybe the culture needs to be changed and how you would change the culture. And maybe, again, thinking about the people who are in the room, who are trainers or who are delivering training and care packages. You know, how are you going to do this and how are you going to change the culture? Because it's not just about finding new inventions or new applications, but it's about changing people's attitudes.
Thanks very much indeed. Just to remind you, one of the exhibitors is around all sorts of technology, so during the next break you might want to have a look at that, any or all of you. We have a question here, I think.
Hi, this is a question for Martin, please, to use your connections, your knowledge. Going back to the age-old problem of money, what do you think the government is going to do with the results of the cost of care? My concern is that I'm traditionally sceptical about their ability to collect figures that reflect the true cost. So if the cost comes out as very low, then providers will not be able to provide it for that cost. If it comes out at too high, then the government won't be able to afford to pay it. So I just wonder what they're going to do with that information, bearing in mind that there's a drastic spectrum of costs. Sort of older, smaller homes will obviously will be able to provide a service much less expensively than a newer home. And if demographics are going up and we're expecting to provide residential care for more and more people, anyone who's trying to build a home now would know that it would be impossible to do it for any fees that are charged at the moment. So I just wonder what they will do with those figures.
Yeah, I think you're absolutely right. I mean, I have a real concern that what we'll do is we'll either get a cost of care exercise which identifies the real costs of care, and then local councils will say, well, we can't afford it. And I think that's already happened. Jane and I were talking about this earlier, where a local council did a cost of care exercise and then sent an email to all their providers saying it's come out very high and we can't afford it. So I think that's going to be a real challenge. And also, I'm really conflicted by this because I think we've got to get much more data in our sector in order to be able to say this is what it costs, this is the data set that you need to be working on. So I've been encouraging people to engage in cost of care exercises, but also to be realistic. And I was noting in the report that Care and Support West has done, you know, there are big gaping holes in some of the information and data that they're not collecting. And I think that is a real problem, and I think your report identifies that. So I would say to providers, make sure you give them what it really costs. Think about what Mei-Ling said about sustainability. Think about what it costs to also ensure staff have a proper approach to terms and conditions and salaries, so that we get into a position where they really understand what the real cost of care is. Then we may well have to go into battle around how is it going to be affordable, and it certainly will not be affordable on about 4.4 billion, which is what the extra money is going in, is going to amount to. So I think my advice would be put in your costs of care, make them real, make them future-proofed as well. Don't just think about it in terms of now, but think about it in terms of the future. Because there are two elements to this cost of care exercise. One is the data they're collecting on what it costs now, but then from that they will have to think about sustainability and market development. So go into battle with some of that. So make sure that whatever you do, you put in realistic costings and then have the debate about, well, what it costs versus what they're offering.
Martin, whilst I still have you there, Martin, can I ask your position, or because you're nationwide, it'd be really interesting to hear from you. I know that we're talking about ICS and things later, but our experience here is that we're having great difficulty in getting social care around they changed the names, don't they? I think it's the integrated care, the partnership boards now, I think they're called around here. But what's your experience elsewhere in the country? Are people having that same kind of issue and problem?
Yes, they are. And I have to say I'm very cynical because I'm so old. I remember coterminosity. I remember joint appointments. I remember the PCTs. I remember CCGs, all of which were going to deliver the holy grail of integration, none of which did. And to give you an example of how everything is dominated by the NHS, a friend of mine has become the chair of an ICS, and he was having major problems getting home care staff. And I said to him, well, you're looking at everything in a silo. I said, there is a lot of green money in your area, so why don't you get a fleet of electric cars? Why don't you put some charging points in local care homes, because they're all over your borough, so people will know they can go to the charging point. That will be really helpful. It will be an incentive to somebody to have the job, because they'll get the car. It won't be taxed because it's environmentally friendly. So he put me in front of his ICS senior team, and the first half an hour they spent telling me why it wouldn't work, and they said ridiculous things like, well, we don't know how to run a fleet of vehicles. And I said, so you don't have ambulances then in your area? And there were all these things that they were trying to say were problems, and we tried to go over those problems. Anyway, my friend rang me 2 days later, and he said, this is going to kill you. He said, I had a meeting with the senior team this morning, and on balance, they thought you had a good idea, and there's one slight change. They want to implement it for NHS staff moving between different services. And I thought that was a real indicator of the mountain we have to climb, because the reality is the structure of these new ICSs are dominated by the NHS. Yes, there are the partnership boards, and I would urge everybody to get involved in those partnership boards, but, you know, you can do what you can do, but if the decision-making power is all vested in a group of people who are completely ingrained in the NHS culture, this is not a recipe for radical change, in my view. And I think it will be another missed opportunity. It will be another amount of money spent on headed paper changes and moving the offices, 200 metres down the road, and it won't deliver a quantum change in the way in which services are developed, or indeed how they integrate to deliver outcomes for people who need care and support.
Thank you, Martin. Not news to us, but it's good to hear that we're not the only area in which we're wrestling with that, and we shall continue to wrestle. Thank you for all of those questions. I don't think there are any more. So there's a break now. If you ever needed any persuasion to go and see the exhibitors, I can tell you that there are now scones and all sorts of things down there to eat. But you probably didn't need that to encourage you. And donuts and everything. I'll give you a shout when I'm wanting you back. Thank you.
Hello, everybody. Welcome back. I hope you're all refreshed after your coffee and donuts. If everybody could make their way to the table now, that would be great. Just a quick intro for myself. I'm Holly Hardy. I'm the clinical lead of the Bristol, North Somerset and South Gloucestershire Training Hub. And I'm a GP by background, so I think I'm in a minority in the room, but I'm absolutely delighted to be here, and I promise I'm a friend of care, even though I may be on the health side. I work very closely with David and Care and Support West in my training hub role, and I'm really, really delighted to be here today and listening to all the excellent speakers on offer. So thanks for having me, David. So session one. Can you all hear me okay? Is the sound all right? Yeah, it's a bit squeaky. Maybe move away a bit. Is that working? Session one was very provocative, looking at sort of system change. So I took away from that a few bullets for myself. One around social care being a profession and not a job, and I really do see that in my day-to-day life, and I think that's a really important thing for us all to keep in mind. The issue about long-term sustainable funding came through really strongly from both speakers, and I think we can only all agree with that. Mei-Ling talked about sustainability at local level, and I like that idea about trying to have sort of local solutions, and also about support for the workforce, and that's probably what the training hub and my colleagues at the table over there are all about. So that's around training and support for the workforce. So in terms of session two, I'm delighted to welcome our next two speakers, starting with Stephen Beet here, who I understand started his career in social care 25 years ago in a care home for people with learning difficulties. And since then, he's trained and worked as a social worker and been in various management roles. And he's currently the Director of Adult Social Care in Bristol City Council. So if you want to add any more to your introductions, Stephen, please do, but delighted to welcome you to the conference. Thank you.
Thank you. Thanks for the introduction, and thanks to the first two speakers. I'm really glad I was here to hear from them, and hopefully we can build on some of the themes that they covered. So, yes, I'm Stephen Beet, and I am the Director of Adult Social Care in Bristol. Thanks for sharing my background, because it saves me doing it. But it is really important to me, actually, the fact that I did start my career working in a care home, working directly with people with learning difficulties, and thinking back to when I was doing that job then, it was all about the lives of those people I was working with and the dignity of those people I was working with. And I saw good practice and I saw some not so good practice, but I really wanted to develop my career in social care, and I'm never expected to be doing this job at that time, but it's a great honour to be doing it. I'm going to talk a little bit about some of the challenges and opportunities we face from the local authority's perspective in social care, and then I'll be handing over to Helen, Holland, afterwards, speaking as an elected member. So who are we? why are we here? I'm actually here mainly because Hayley Verico couldn't come. So, no, it's great. It's great. It's really nice to be able to talk to providers and actually be part of this conference. And it's also really nice to be doing this with Helen. The relationship between the Director of Adult Social Care and the elected member is really important. Although Helen's not my boss in terms of I don't report to her for management, she holds me to account for what we're doing in relation to adult social care in the council. And she's holding me account because I'm accountable to the citizens and the people of Bristol. And I know that that's what motivates Helen, and that's what she's most concerned about, is that we're doing the right thing for the citizens of Bristol and that they're getting the best opportunities. So just in terms of, like, I'm not going to dwell on this, but the national picture in social care, I'm going to talk about some of the challenges, but I am going to talk about the opportunities that we have. And I'm not going to go into the detail, but there are, you know, demographically, we are seeing an increase in older people, an increase in dementia, higher rates of people who have disabilities and learning difficulties, but we're also facing a cost of living crisis. And that's a major concern for us in the local authority, and I know it is for care providers as well. I'm concerned that the cost of living crisis is actually going to bring people into the social care system because it will affect their health. It will have an impact on people's health and well-being, having to make difficult choices between whether they can afford to pay for their heating or buy food. So it's a really, really important thing at the moment that we understand the impact of cost of living, and that we're doing everything we can, working with our colleagues in public health to address it. So this is something, when we're talking about social care, we've got to think about what this is actually about, the people we're here to support. And we often bring out this slide and this quote, which is from Social Care Futures. Don't we all want to live in the place we call home with the people and things that we love, in communities where we look out for one another, doing the things that matter to us? And most of us don't have to think about that because that's just part of our lives, that we get those opportunities and those choices. But, you know, for people that use adult social care, they need that support, but they should have the same opportunities as much as possible as anybody to live and be part of their own communities and live as independently as possible. So over the last, particularly the last 2 years, it's been a challenging time, obviously, in the whole sector, and it's been a challenging time for the local authorities, but also a time of great opportunity to do things differently and work differently. Actually, in terms of the pandemic, it changed the way we worked, and it did really present some opportunities to work really differently, especially in terms of integrated care with our health partners, how we can engage with you as care providers, but also some significant challenges, both in the way that we have had to deliver care to people and the lives of the individuals that need to use social care, particularly in terms of social isolation and people being able to actually access local services, access their local communities, especially during the times when many of those things were not available to them or not operating in the same way. We also faced really big challenges around workforce, and it was I was just talking to my colleagues on the Bristol Proud to Care stall, actually, and we were talking about recruitment and how we saw that really difficult time at the end of the summer when the restrictions were lifted, and we faced all this competition from other sectors such as Amazon, and we could not recruit care staff, we couldn't retain care staff. Many of our care providers some of them were having to hand back care to us. So it was a really difficult time, and it has improved. And actually, we do have really good stories of people coming back into care and into the care sector, and also people that have got transferable skills coming back into the care sector from different industries. So I'm feeling a bit more optimistic, but I know we're going into the summer, and that's always a challenging period. But we've heard about it this morning. We have to raise the profile of working in the care industry, the opportunity and the funding that comes with it. There's been huge pressure on our hospital systems, particularly through the winter and throughout the pandemic, and it was referred to earlier about that challenge of people leaving hospital and adult social care often being seen as a problem because there's not enough supply, there's not enough home care. Lots of demand, particularly, we've seen an increase in demand in local authority, particularly people with mental health needs and more challenging behaviour, and that's related to the impact of the pandemic. So a higher proportion of people with more complex needs. And really want to mention unpaid carers, because it's so important that we work alongside unpaid carers who've, you know, for many unpaid carers through the pandemic, they would say, well, this isn't that different to us because we couldn't actually go out, leave the house that much anyway. But we've really relied and depended on unpaid carers, and we have to work with them and support them. And then it goes without saying, the huge budget pressures that we face in a local authority makes my job really challenging. But we have to do the right thing with the money that we've got. So, yes, we need more money in the system to deliver the right outcomes for people. But I know that in some cases, we end up paying for the wrong things at the wrong time. And that's because of those challenges that we face, the demand that we face, where we can't get out to review people at the right time, and there's people's care breaks down, or we're ending up paying for one-to-one support on top of people's care because they're in the wrong environment, and that's often because of the safety of the staff or the environment, rather than the actual, because it's in the best interests of the individual. So those are some of the challenges, but where we're trying to go, where we really want to move towards is much more personalised support. So strength-based, asset-based approaches, where we really, as I said, that quote at the beginning, we really focus on people's strengths and their dignity and the opportunity for them to live fulfilling lives. And we need to do that by new models of care, and I'm really glad that we talked about, I think technology has been referred to a few times today, and absolutely we have to embrace the use of technology to enhance the care we deliver and as an alternative to care, because it enables people to live more independently, and technology is the future, isn't it? So it doesn't mean that we won't still need traditional forms of care, but we've got to really consider the way we use tech. Home First, going back to talking about people leaving hospital, Home First is actually a programme of work that we have which is all about the pathway for people leaving hospital, reducing the need for people to go into hospital, but mostly it's about making sure that they get the right support when they leave hospital that maximises their independence and supports them to stay in their own home. And what we've seen through the pandemic and through some of our difficult winters is that we just address those problems by buying more beds. We've used care hotels. We use things which are not which help people leave hospital, and that there is a level of harm that people experience by staying in hospital for too long. So we have to address it. But we've got to think long term about what people need once they leave hospital, supporting them to be back into their community, receiving the care that they need at the time, reablement, intermediate care services, and actually, longer term care for providers. So as providers actually working towards improving people's independence. The care reform I'll come back to a bit later. But we've got a lot of it coming our way. Integration and locality partnerships to include care providers, and I'll talk about that in a minute. We need to continue to respond and model the impact of the cost of living crisis. And we've got to continue to manage and control our budgets and our spends. And we need to have transparent pricing methodologies. So we need to know that we are paying what we should be paying, enabling providers to be able to pay a meaningful wage to their staff, paying the national living wage, the real living wage, and methodologies that we know that are transparent, that we've all signed up to, that we know what we're getting for our money. And we have to work with you. And we'll talk a little about the cost of care process in a minute. And then continuous sector-led improvement, which is to do with our CQ assurance requirements that we have coming. So a bit of a busy slide, but this is our care ladder, and actually this is the model really that we're trying to work to in Bristol, is around moving people away from the higher end of more complex care wherever possible to a more reablement, rehab-focused type provision, and also making sure that people are receiving support within their local communities from a range of different places, including the community itself, the businesses in that community, and the voluntary sector. But we still need the traditional models of nursing, residential care, supported living, but we just need to make sure that they're focused on the well-being of the individual and using technology. And, you know, for some people, residential care is their home, so it's okay. Being at home doesn't just have to mean having your own tenancy or owning a home. It's actually that can become your home, but it needs to feel like home. So, again, this is from Social Care Futures, where they've actually developed their own priorities for people who draw on services. So, communities where everyone belongs, living in the place we call home, leading the lives we want to live, more resources better used, so making better and more effective use of the resources that we have, and sharing that power as equals with the people that draw on services and between providers and the local authority. So in terms of, I suppose, my commitment to working with care providers, with the care sector, it's really important that it feels like a partnership and not a transaction. When we moved to what we call the kind of purchaser-provider split, I think back in the late 90s, it became quite a transactional thing, commissioning. And we need to change that. We need to work in partnership with you, and we need to have stronger partnerships and relationships with care providers, but also how you work in partnership with each other. So commissioning doesn't just feel like a transaction. We buy care and you supply and provide it. We have to work with you then on ensuring that we maintain the quality of that care, and that we buy outcomes, not just inputs. So actually we need to trust providers to deliver outcomes, and that might be that you're working with someone through a pathway towards greater independence, or moving people onto a different type of service, or helping people use technology in different ways. Not just, we bought this, now off you go and provide it. We need to value the workforce. We've talked about that a lot already today. How do we make sure that the working in the care sector is a really good, positive place for people to work? We've got to have, talked about earlier, realistic and transparent funding agreements, working alongside each other and our voluntary sector partners, because they're a really important part of the system, our voluntary and community sector partners. And our wider community, actually, that's, you know, the services and the organisations, the shops, the cafes, the places that people actually go are part of the integrated care system. We need to maintain quality care. I'm really proud, actually, that in Bristol, 95% of all our care providers are rated good or outstanding, and that's really amazing, you know. I mean, and really appreciate the amount of work that goes into achieving those standards and those ratings. So we're very, you know, we have really good quality care in Bristol. And then, of course, how we work with unpaid carers who are providing care for people, maybe alongside a care provider, maybe on their own, but might need to draw on services in the future. National Carers Week is coming up, so really opportunity to celebrate the great work that unpaid carers are doing. So yeah, working in partnership is the way that we need to do this, and a less transactional approach. I'm just going to summarise some of the social care reforms, but you've heard about some of them already, so I'm not going to go into detail, but there's quite a lot for us to do in the next 3 years in social care. So alongside those challenges, there's quite a lot of reform that we've actually got to deliver. We've got the Adult Social Care Reform White Paper, which came out in December, then the Build Back Better plan for health and social care around the capping of care costs, health and social care integration joining up care for people, places and population. And then the Health and Care Bill actually comes into play in the July this year around the establishment of integrated care systems. We've also got the changes to the Mental Capacity Act, which is going to be replaced by the Liberty Protection Safeguards. So we're doing the work on that. And then by April 23, we will have the Adult Social Care Assurance Framework with CQC, where we will be going through the assurance process and inspected by CQC. I'm not going to go into detail around, so starting with the integrated care system, I'm not going to go into detail because you're going to hear a bit more about that from Jeff Farrar later. There's obviously quite a lot of bureaucracy and governance around the integrated care system, and different boards, different functions at different levels. This slide just describes what those different things are and what the ICS is actually about. But it brings together the health and social care system across Bristol, North Somerset and South Gloucestershire. It breaks that down into 6 locality partnerships, and 3 of those are in Bristol. So we work really closely with those locality partnerships. They're quite well formed, actually, in Bristol, and there's 6 across the whole footprint. So it's our integrated care system is made up of 1 system, 3 local authorities, and 6 locality partnerships, 3 of which are in Bristol. And a number of different organisations are part of that, but I wouldn't limit it to these ones. Care and Support West, we've worked really closely with David and colleagues to make sure that care providers are represented at locality partnerships and more generally across the integrated care system. It's really important that care providers are seen as part of that alongside voluntary and community organisations. This is kind of, more of my interpretation, a simple interpretation of what an integrated system really is all about. It's about organisations working together for their communities and by their communities, not doing to, but actually doing with. It's about more joined up care. So how do people actually access care without having to make separate referrals to social care, separate referrals to the NHS, and making it much easier for people to access what they need. And that might just be support from their local community. A real focus on people's well-being and what we call the wider determinants of health. So that's about every factor in somebody's life, about the transport, about housing, about air quality, about local community. Those are the things that impact on people's well-being as well as their actual health. And I think in our locality partnerships, we've really influenced as a local authority the focus away from just being around how people access health services to actually being about well-being in their community. Home is best, and then moving towards how do we joint commission services and move towards more pooled budgets in the future. This is the vision, just to give you an example, for South Bristol, which I'm the chair of the locality partnership in South Bristol, to deliver meaningful care and support that enables individuals and communities in South Bristol to optimise their own well-being. So then we've got the funding reform and care cap. We heard a lot about that earlier on from Professor Martin Green. So I won't go into the detail of this, but I'm sure these slides will be circulated. But it does mean that the upper capital limit will increase to £100,000 and the care cap set at £86,000 from October 23, meaning that we have to develop individual care accounts as a local authority. Anyone assessed by the local authority as having eligible care needs can begin that process from 2023. Now, the modelling that we've seen on this actually means that this will require an additional 400 Care Act assessments and 300 financial assessments, and that would equate to around 28 additional staff for us. So it's quite a challenge for us when we're already challenged around how we undertake our assessments and reviews in the local authority to have the additional burden. So we're working with colleagues around our preparations for the funding reform and the impact. You heard about some of the concerns earlier from Martin. The fair cost of care exercise, we talked quite a lot, heard quite a lot about that earlier. We're going through that process in Bristol, working really closely with you, working with Care and Support West in terms of how we go about that. It's a process that we have to go through within a time scale, and within following the guidance, for the national guidance in terms of how we do it. So I think there's something here about this is a fair cost of care exercise that we have to do, but there's another piece of work really around what is a fair cost of care, and we've got our challenges to make sure that the two things match. And the challenge, as was mentioned earlier, around self-funders and how we can develop a standard rate for self-funders, I understand is going to be a real challenge for care providers who are reliant on self-funders paying different rates. So it's going to be interesting how that works out. And then finally, CQC assurance. So that's something that's coming where we will actually, as a local authority, be inspected by CQC, just like most providers are now. So you're very familiar with that process. The main areas that they'll be looking at will be around our practice under the Care Act, our performance, our partnerships, including partnerships with care providers, the pounds, how we're spending the money, is it cost effective, and the place. And I actually really welcome CQC assurance coming to adult social care, because it means that we will have that continuous sector-led improvement approach. And we've already started doing that work around understanding what we're doing well, what we need to develop in the local authority. So it's not just about when the inspectors come in, it's about understanding our performance and what we need to address and what we're doing well. So it begins in the spring of 2023. We've been talking to CQC about the approach because it is very focused on our Care Act duties. And in many ways, things have moved on and changed through the pandemic in terms of the way we work, and the way we work is a much more integrated system. But ultimately, we will be monitored on whether our services are safe, effective, caring, responsive, and well-led. And I think those are good words to end on, because those are the most important things around how we deliver care as a system for any provider and any local authority. So I'm going to finish there and pass on to Helen. Thank you.
Thanks very much, Stephen. We're going to segue straight into Helen, and then there'll be roundtable and Q&A afterwards, so save all your questions for then. So welcome Helen, who is the Bristol City Council elected Cabinet member with responsibility for adult social care and integrated care system, and chair of the Health and Wellbeing Board. You're very welcome today. Your talk headlined as Elected Member Dilemmas. I love that. So step up.
Thank you very much, Holly, and thank you, David, for inviting us, and thank you to Stephen for doing the kind of formal bit. And you might be wondering about, well, what's the role of the elected member in all this? And I'm going to try and give you a bit of a window into my world in the next sort of 10 minutes or so. And I'm going to start with the biggest dilemma of all, and it's been referred to lots of times already this morning, is about where does the money come from? We all know that in a perfect world, we'd be able to ask for social care to be adequately funded. But as council taxpayers, whether you live in Bristol or whether you live elsewhere, you also know that you want value for money from your local authority for the things that you care about and that happen in your local community. Now, if you're a Bristol council taxpayer, I don't know if you took the trouble when your bill arrived a couple of months ago for this year to look at the leaflet that's in there with the bill, or whether you just and throw it away. But there's a pie chart in there, and there's a pie chart every year. And this year, for the first time, the pie chart showing the spend on adult social care went over half of the pie. So of Bristol City Council's funding, 51% now goes on adult social care, and I have the political responsibility for that budget, which, as you might imagine, gives you a few sleepless nights. If you're in some of the surrounding local authorities, I think it's even higher, and it slightly depends about how you do the maths, but I think you can see. And there's a kind of delusion almost out there that because we add on the adult social care precept, that means that all our spend is covered. But I think I'm right, Stephen, I was just trying to work this out before the break, that 1% only brings in an extra £3.5 million. Well, you can see that on a spend of over 180 million within adult social care, actually another 3.5 million isn't going to really change things. So I think that that's my starting point. And it does mean that politically, and I've just celebrated, I have celebrated. I was first elected to Bristol City Council in 1991, so I've just celebrated 31 years as a elected member, and I've had all sorts of jobs and political responsibilities in that time. I've been doing the adult social care portfolio for the last 5 years. And when Mayor Marvin Rees gave me that job, he had a bit of a reshuffle a year after being elected and told me that I was adult social care. I was like, oh, God. Because I think there's a bit of a sense that it's a poison chalice because of the challenges that you've been hearing about all morning. So my question to myself was, well, what can I bring to that? And I think what I can bring to it is the variety of other roles that I've had in the past. So it's the links, as Stephen's talked about. Making best use of every pound that we get means making the links with my colleagues in other services in the council. And I have to do that partly politically, because every additional pound that we need in adult social care means that my colleague who looks after libraries and parks has to do a bit more with less in their department. We were talking on our table about everybody notices when the council, whichever local authority you're in, but when they change to fortnightly bin collections and everybody's moaning about it at the school gates or down the pub. But how often, really, it might happen more so in your worlds because people know where you work, but how often do people really think about the local authority role in providing adult social care? And one of the problems, I think we've all recognised this, is that people don't think about it until it happens to them. Their family, a family member needs care, or somebody that they know, or they're worried about a neighbour who they've seen has started not to be able to manage their own affairs. So it just hasn't got the profile. And I'm not looking to be on Points West every night. I'm really not. But for example, there's a cabinet meeting this afternoon. I've got a report to cabinet. There are no public forum statements or questions, and none from any other members of the council about that report. Now, you could say that's because I'm doing everything right and nobody's got any question with it. But I do think it's a question about the profile. And so it comes back to those challenges, which Martin, I thought was an absolutely excellent presentation this morning. And I'm just going to pick up on some of those themes. Because Bristol, I think one of Martin's questions was whether the local authorities who'd got the capacity to deliver on the cost of care exercise. And Stephen's just said about what the implications of that are to us. But the local authority lives in the same world that you do, with the workforce challenges, with the challenges to linking up these agendas, and that's very much about the developing work on the ICS, and I'll talk about that again in a bit. But I come back to the point, it's not underpinned by enough money. And it's not just over the last 20 years, is it? I think people who've been around longer, in this world know that all sorts of white papers, green papers, parliamentary bills, all about, oh, we're going to change it, and we've got an oven-ready answer for the delivery of social care, but that just hasn't happened. So for me, a lot of it is about achieving the council's ambitions in all sorts of other areas and linking with as many partners and partner organisations as we can to deliver against those priorities, and not waiting for government to tell us what to do. Let's push the boundary, let's do it properly in Bristol and BNSSG, and be a leader in this field. So some of those other council priorities, obviously, and we've spoken about it already this morning, the cost of living crisis is very, very real. And I don't know if any of you were able to go to the city gathering that Marvin held a week last Friday. I wasn't there, it was the first one I've missed, but it was for a good reason, because I was on my way to Nottingham to celebrate my mum's 100th birthday, so I'll just throw that in there. But at the city gathering, I know that the focus on the cost of living crisis was a major one. And there is an implication there for us as well, isn't there? Because we brand ourselves as a living wage city, we want to be a living wage city. There's a cost, obviously, if we're commissioning providers and we want them to pay the living wage, and of course we do, then there's a cost to that as well. Food poverty and fuel poverty are real issues out there in the community as well, and they've been exacerbated by the growing cost of living crisis. And the whole climate change agenda. And I know that within the Health and Wellbeing Board, we've thrown out the challenge to our partners around the board to sign up to the Climate Change Challenge. And the two acute trusts, so North Bristol and, I can never get the letters right in the right order, UHBW, have both signed up. But, you know, take that back to your organisation and see what it would mean for your organisation to sign up to that climate change challenge, because that brings all sorts of other benefits. It brings the ones about air quality that Stephen mentioned. It hopefully will mean, you know, that people and places are better served by public transport and more active travel, all of those things that improve quality of life. And then I just wanted to touch on the role of the VCS, and Stephen covered it, the voluntary and community sector. Stephen covered it partly in his slides. If we're going to have the ambition that more people can stay independent, living in their own communities, then we've got to make sure that the voluntary sector, and I do think that sometimes when government trots out better use of the voluntary sector, that they think it's free. Obviously it isn't. We need to fund the voluntary sector properly, and I know from experience, and I was talking to a friend who's a social prescriber at the weekend, and she was saying that they're seeing more referrals because obviously some of the shortages within the NHS mean that the GPs, quite rightly, are directing more people to social prescribers. But the social prescribers know that many of those organisations that they would normally signpost people to are also at capacity. So it's about making sure that we fund our voluntary and community sector properly, so that those people who can be supported to live longer in their own communities can do so, and that they've got those support mechanisms. But I do think, as I say, that voluntary doesn't mean free, so we've got to pay for that as well. And we work much more closely with neighbourhoods and communities in the City Council than we have done, maybe hitherto. I'm just going to pick up on one of the other challenges that Martin said, and I've kind of briefly referred to this. But I sit on the partnership board of the ICS, and I sit there as the chair of the Health and Wellbeing Board. And in North Somerset, Councillor Mike Bell, the deputy leader of North Somerset, is their representative, and he also chairs their Health and Wellbeing Board. And in South Gloucestershire, It's Councillor Ben Stokes, also Deputy Leader over in South Gloss, but sits on, or chairs their Health and Wellbeing Board. And my view, Stephen talked about, is it one system, 3 local authorities and 6 locality partnerships, or should we say that the locality partnerships are at the top of that pyramid and the 3 local authorities and 1 board? Jeff, our chair, will be here later, and you can ask him about that. But in my view, the health and wellbeing boards have a role in drawing those networks and those partnerships together. So when we go as representatives on the partnership board of the ICS, it's got to be a partnership of partnerships, and we've got to reach right down into the sectors, into organisations like Care and Support West that provide that network for the providers, and that we take that voice up into the strategic body and make sure that it's heard, because it is very much NHS dominated, and we are trying very, very hard. The integrated word should mean that, and it should mean it's about the local authority integration. But I think one of the things that Martin said this morning, it's not about organisations, it's about people and outcomes, and I absolutely passionately believe that. And I want us to push the boundaries on how the BNSSG ICS develops. And he also said, we can't wait for government to do what needs to be done. We need to do it ourselves. So if we can see what needs to happen, then let's push that boundary and let's make sure that that does happen. I'm going to just finish on the point about workforce, because this is a really, really important one for me. Because my ward, for those of you who are Bristolians, you will know exactly where I'm talking about. My ward, and I've represented those people for 31 years, is Hartcliffe and Withywood. And when you think that in our city, which has this perception out there, doesn't it, of being this kind of, you know, go-getting, young people's hip place, in my ward, there are 5 what they call super output areas, which is sub-ward level, which are in the top 1% of deprivation in the country. So that's like the Liverpools, Middlesbroughs, those kinds of places, and we've got it right on our doorstep. Now, why is it that we can't reach into Hartcliffe and Withywood and excite young people there when they're coming up to leaving school about the potential of a career in health and care? Why are so many fewer of those people in those? And Hartcliffe and Withywood isn't alone. You could say the same about Knoll West, Lawrence West, and many of the peripheral estates. Why is it that those people don't engage with that idea as something that this is a career that's worth pursuing? We really, really need to work harder at growing our own people and giving them those opportunities. That's better for the health and well-being of that community, people earning money and bringing it back and spending it there. And it's also better, gives those people real life chances. So the workforce one, linking that to the city's ambitions about making the city a less divided and unequal place is really, really important. And trying to link that to some of the city's other agendas around climate change, cost of living, fuel poverty, and so on. So I hope I've given you a little window into my world. What I forgot to do right at the beginning, and I determined that I was going to do this, was to say a thank you to all of your organisations, especially for the work that you did over the last couple of years. I think that what that showed was that there was a real willingness for the local authority to work in partnership with the providers that we have, with the NHS, with the community health provider, Sirona, and so on. And many of those relationships are much better, ironically, because of the pressures of the pandemic. But please take my thanks and that of my colleagues in the Cabinet back to your organisations and give them a huge pat on the back for how they managed to keep the city and our residents going over that period. But I'll finish there, and I hope that you found that of some interest.
Thanks very much indeed, Helen and Stephen. A few nuggets I picked up. So from Stephen about supporting and working with unpaid carers. I think that's something, certainly as a GP, that I don't think about all the time. And about sharing power with clients or patients or whatever name you want to use with the people. And then from Helen about making links with other services and partners. Again, I think in health and care we need to sort of grasp the nettle with that one. And about growing our own workforce. Definitely some food for thought. So we've got about 10 minutes, I think, have we, David, for sort of round table, if you all want to kind of gather into your groups, and if you're on a table with not many on, maybe join some colleagues and have a talk about these two presentations and any questions that you'd like to raise, and then 10 minutes for questions after. So enjoy. Thank you.
Okay, people. Hopefully your discussions are going well. So if you've got questions or comments in relation to anything either Helen or Stephen said, now would be a good time to raise your hand, and either Holly or myself will come to you. There's one over there, Holly, to your left.
Hi, you both mentioned that you'd like Bristol to be a real living wage city, and you'd like providers to pay the real living wage. How does Bristol City Council intend to support providers that do provide the real living wage? Because we kind of feel we're penalised by doing it at the moment, because we don't get any extra money or rates for it, and we don't get preferential treatment on winning residents from yourself. So how are we expected to pay for that?
That's a really difficult question to answer, given the financial challenges that we face in the council, but we've got to make sure that we make the best use of the funding that we have so that we can pay a meaningful rate. We did increase our rates with inflation in the new financial year, but yeah, it's really difficult, isn't it? I recognise the challenges that you face in paying the real living wage, and we do want to be a real living wage city and build that into contracts, because we know that that's going to be what ensures that we can really keep the sector going and bring people into the profession. But I suppose, yeah, I'd like to be able to have those really helpful, meaningful, transparent conversations about what we need to pay the sector and how we do that within the limited budget that we have in the council. So I don't have, I don't have an easy answer to that question really, but the more we work with you, hopefully we can, come up with solutions that make that more possible through transparent pricing strategies, and just keep working with you, and continue to work with organisations like Care and Support West to campaign for the money that we need in social care in order to pay meaningful wages to staff.
Thank you, Stephen. Other questions around the place? If not, one of mine to you, Stephen, is around the cost of care. I'm interested to hear from your perspective, from the local authority's perspective. We talked earlier about the toolkits that are being used, capture data for 21-22, and what we're all interested in is funding going forward, 23, 24, 25. I know you are too, but how are you going to ensure that the organisations that you've commissioned to do the cost of care exercise are going to not only capture data from last year, but also forward on?
Well, obviously what we've got to do this year is required by nationally that we undertake this exercise. So yeah, we do want to make sure that we consider what's going to happen in the future beyond that, particularly taking into account the cost of living crisis. So I think that's about how we work in partnership with you, again, to make sure that there's a cost of care process that we have to go through, but there's also I guess, an opportunity to work with care providers around what a meaningful cost of care actually will be in the future. And how, again, it's just similar to what I just said, really, how we can work with you to, within the budget that we've got, to support the sector as best we can within the limited resources that we have. But yes, I agree, it should be an exercise that we continue to do, so that we can pay rates which will actually, support your organisations to continue.
Okay, thank you, Stephen. Any other questions? Got one over here. Hold on a second. I shall rush over.
Hi, my name's Sarah Ambay. I'm from Promoting Independent Care. We've got about a 95% BAME workforce, and one of the challenges is around challenging racism when some of our service users only want a white face, and it's unacceptable in this day and age, and we challenge and we give notice in those situations. But I think on a wider structural inequalities basis, getting the support of the wider community and can the council and the integrated care systems do something around letting the public know that it's not okay and we don't have a bottomless pit of support staff. So, could we have a response on that, please? Can we do some more work on challenging inequalities?
Yeah, absolutely. I'm really glad you raised that. We should have a zero tolerance policy and a zero tolerance agreement on any forms of discrimination, or particularly racism. So I know our own social work staff have experienced those challenges, and someone who's delivering care is delivering care, and that should not be a factor. And we need to make sure that we are working with you actually to support you to make sure that that isn't acceptable, and we won't tolerate that. So I do think that the integrated care system is an opportunity for us to address inequalities, particularly in different areas of Bristol, and challenging discrimination and oppression that you describe. I think I'll let Helen come in.
Yeah, I was only going to add, and we had this conversation over the break, so one of the things that we are doing is working with diverse communities within Bristol. So some of those organisations that are led by the diverse communities are doing a fantastic job, and we're working with them at getting CQC registered and all of those things. But some of the kind of side stories of that, I do think that there's a real role, obviously, as you've said and as Stephen has said, in tackling that and saying it's not acceptable. But it's also some of the outcomes that I hear from some of those organisations are ones that actually add to community cohesion. So where people, for example, in the inner city, there's a Somali-led organisation, and the leaders of that organisation have told me that whereas maybe to begin with, they'd had some of that pushback, oh no, we don't want, which is completely unacceptable. But what has happened when those carers, with all their skills and a knowledge of that changing population in that particular area, that they found that having a cup of tea together, sharing some of their, the annual celebrations, all of those things have actually brought those communities much closer together. So I think it's important that we've got a diversity of provision, but it's also not that that's a Somali-led organisation and that's only to meet the needs of the Somali community. It's got to be that we're meeting all needs across the city. And I think if you've got ideas, both if you've got examples, tell us about them, but also if you've got ideas about promoting people from all walks of life in care professions, and I know that you do that, David, through the awards, then, let's hear it and let's try and get those stories out there.
Hi, my question was back to finance again. We all know there's not enough money in the system, but what I'd like to ask is, how are care providers supposed to maintain our standards over this coming year? So we've had 4.5 inflationary uplift. Our payroll's gone up at least 9%. Our energy bills are going up 100% in some cases, food 20 to 40. So we talk about food and fuel poverty, but that can also apply to us as care services and our residents. So I'd be interested to have your thoughts.
I mean, again, it comes down to making sure that those issues are reflected in the cost of care exercise so that we can really go back. Because I don't think anyway, say it any more clearly that we have not got more money that we can call on within the City Council. So it means that the system has to be properly funded. I mean, Jeff's here and going to be speaking later as the chair of the ICS, and some of it will be about reapportioning some of the money in the system. But everybody who's spoken this morning, from Professor Green down, have said that there is not enough money in the system. One of the other things, and I was going to add this on Stephen's earlier answer, is that I know it's a great frustration, David's raised this with me many times, is that we work on an annual budget. That is the legislation for local authorities. We can't give you the reassurance that you need that we're going to be able to give you an uplift every year until we've been able to see what the state of our budget is. So it's a challenge, and we understand that's a challenge for you.
And I think just to add to that, because these are really difficult questions, and it's not, I do really feel that we have to, it's challenging for all of us and we need to work together. But bringing it back to the care ladder, it's about making sure that we are as efficient as we can with the money that we have and spend it in the most cost-efficient ways. So actually, by using technology, by building, stronger communities, it will mean that we shouldn't need to spend so much money for so many people who need the higher cost care. And also that we try and stop people reaching crisis point and actually think long term about how we're supporting people to live as independently as possible, particularly for younger people coming through education that we're going to be supporting in the future, supporting them to be able to access education and access employment. So we've got to use the money really wisely and fairly across the system so that we can pay meaningful rates for people who do need that type of care.
And the last question for this session needs to be here, I think. You want to come back, Sam?
I just wanted to come back about the budget again, because you've got a set budget, but so do we. And so we have to do all of these things with that set budget, and it won't stretch as far. So our standards, we've got to get the level, and we've got to get an agreement between us what's going to happen to those standards. And perhaps it's something we need to talk to CQC more about as well, because we just can't stretch it to do everything the same as you can't.
I mean, there is new money in the social health and social care levy. What I want to understand is why much more is not being done to earmark a far greater proportion of that budget to social care, when it's quite evident to everybody who knows about it how necessary that is. Now, at the moment, we sort of say, well, however many, 37, whatever it is, the NHS can have most of that for the next 3 years. Well, that's not going to help social care, is it? I don't understand that that's not, your doing in any shape or form. I fully appreciate that, but there doesn't seem to be much of a collective voice holding the government to account, Boris Johnson to account, when he stood on the steps of Downing Street when he took over as Prime Minister, saying, I am going to fix social care. Well, he's not in any shape or form fixed social care. He's just overseeing its sort of slow and steady demise. So just thoughts in relation to that. So we're all talking about we need to, yes, we need to be efficient with what we've got, but we haven't got enough. There's a sort of big pot there, and actually we're just letting the NHS have it, in effect.
Yeah. I agree, and that's been a frustration, to me and my colleagues who have the same portfolio as me up and down the country. So I speak to the people in the core cities, the London boroughs, our comparator authorities and there are regional networks, and we're all in exactly the same position, irrespective of the colour of political control. And I think that the umbrella organisations are making representation. Certainly ADASC, the Association of Directors of Adult Social Care, does it, and on the political side, the Local Government Association is making those representations. And you're quite right that people say, oh, well, you've got the levy money, but under legislation we can't charge more than, I think it's 2.9% or something, without having a referendum, if you're going to increase the council tax by that amount. And as I've said, every 1% is only 3.5 million in Bristol, and in the other two authorities it'll be less because the population of them is less. So there's a kind of view, well, you've got this extra money, but the proportion of it that's going to the NHS and the proportion that's going to social care just makes the case for the integration agenda to work better for us.
Thank you both. I'm going to stop the questions there. Can I, though, urge people to either take this report away with them, if you're a provider, and or go to the website and get it as well, because it is on the website, Care and Sport West. In here, you'll find something like 2 or 3 pages of information about the things that you need to include in your cost of care information you send back to the local authority. If you follow this document and put everything in and then some, just put everything in that you know you're going to be that it's going to cost you to continue your business. Put absolutely everything in when you're doing your cost of care exercise, because what we need to do is we need to hold the local authority to account for giving the right message back to central government. And they can't do that unless they get the right message from you, from us. It's a really significant point. Been lots of discussion on it this morning. I know that both Stephen and Helen would want to make sure that that happens from Bristol and North Somerset and South Gloss and Bath and North East Somerset. But if we don't give them the bullets, they can't fire the gun. So please take it away, go to the website, make sure you give them all the information you need to do. Thank you. I was going to say I'd get off my soapbox. I'm not even on it. But you know what I'm saying here. So we're ready to move to the final session for today. Happy to welcome Jeff Farrar here. He'll introduce himself and tell you all about himself from the integrated care system point of view, as it were. And then Jane Townson is going to talk to us about things from the Home Care Association. And then Debbie, I saw her earlier. There she is over there, from CQC, is going to finish up this particular session. And then we'll go to another roundtable and Q&As. Please, can I remind you again, still to be putting down on your list the things that you want your care association, us, to be doing with you and for you after this conference. This is your chance to be saying to us what you want us to be doing for you. Jeff, you're very welcome.
Send some slides over. I don't know if they're...
Yeah, they should be. The little clickers there.
The green button?
The green button.
Okay. Well, thank you, everyone. Thank you for the invite today. See, David's put me down on the agenda as talking about marriage. My wife would probably tell you I'm not the best person to talk about marriage, but I will do my best. And it's about the marriage between health and social care, so I'll pick up a number of the points that have just been discussed. For those who haven't met me before, my name's Jeff Farrar. I'm the Chair Designate of the Integrated Care Board, and I'll come on to that in a moment with the new systems. Prior to that, I was the Chair of University Hospitals Bristol and Western for the last 3.5 years, and prior to that, I was a police officer. I was a police officer for 35 years, and I was a Chief Constable for the last 6 or 7 years of my policing career. So this isn't virgin territory for me, but I don't underestimate the challenge. And as I go through, you will see why I think we've got to wholesale rethink the way that we work together, because the system as it is now is not sustainable. It's not sustainable financially, it's not sustainable operationally, it's not doing the best for our citizens, and so we just need to make sure that we are more joined up and working more as one public service. So the integrated care system has 4 key aims, and you will see that's touched on some of the stuff you've talked about this morning already. So the first one around population health and healthcare, the second around tackling inequalities, the third about productivity and value for money, and then the fourth around social and economic development. You will see from this there's a theme about getting upstream, about prevention, about stopping things happening. Our system is not geared up to do that at the moment. So the last question that was asked around finances, if we've got an acute care system at the moment that is in crisis because they've got a huge amount of waiting times, backlog, we do need to do something about that. It's not enough to say we will just shift all the money from here to here. But absolutely, over time, if we don't do that, we're not going to deliver these 4 key aims. And I'll come on to the structures within the integrated care system in a moment about how we will deliver that. But, you know, ultimately, this is about a different way of thinking. If we don't attempt to do some of these things, we know that our poorer people will get poorer by way of health and social care. Many of you in third sector organisations will continue to struggle for funding. And so over time, my responsibility as the chair of the Integrated Care Board is going to be managing some of those finances. So we've probably got £2 billion running through there annually. We do know what it costs to run acute care, and they swallow a huge amount of money from our overall health bill. But I know from the 42 chairs of integrated care systems across the country, across England, every single one of us is talking about you cannot mend this system unless social care is sorted. And so, you know, most of the people in integrated care systems as chairs have got a variety of backgrounds, but a lot of people who've had an NHS career are all saying the same thing. Everybody is saying we cannot do this unless social care is given that support. So let me just move you on to this, and it's a busy slide, but it gives you some idea of the structures. So we're going to have a partnership board, which up until now I've chaired, and the partnership board up until now has been our 10 partner organisations. This is going to be a much bigger board. It's going to be chaired by Mike Bell initially, who is from North Somerset Council, but it'll be rotated amongst our 3 local authorities. So North Somerset and then Bristol. So Helen would be in that role to be chairing that, and then into South Gloucestershire. And we'll rotate the chair of that every 12 months. I think that's a real coup for us. I think a lot of people have talked about the integrated care system as just another NHS reorganisation. And I, for one, have been determined that we think about this in a very different way. And to do that, local government, I think, have a much better understanding of locality, around social care, around all the things that you do in this room than perhaps the NHS do. And I say that for somebody who's been in the NHS for the last 5 years, because that connectivity is there in a different way. I finished my doctoral research last year, and my research was on the incentives and disincentives of cross-sector working. And I can tell you that the most obvious things that you would probably shout out were not the ones that were the most dramatic in that research. The most dramatic ones were around understanding each other's organisations, which we think we do, but we don't. And the second is around our path dependency. So it's one thing to say we need to shift X to Y, but if people are held to account in a certain way, it will affect their behaviour. Now, I've had the conversation with the Chief Executive of the NHS and with the Health Minister about if the NHS at the centre continues to, or not continues, my apologies, if the NHS at the centre arcs around the integrated care system directly into individual organisations, the integrated care system cannot work. So there has to be a pushback from me and from the Chief Executive back into the centre to say, you need to allow us, within the integrated care system, to manage the resources effectively. That will create some tensions. I'm already getting some people within our acute trust saying, well, this all sounds very good, great, Jeff. But where's the money coming from? Familiar conversation. So we're not going to rob Peter to pay Paul, and we do know we'll have some immediate priorities, which will be in the NHS, but I'm determined that we are going to deliver against those 4 key aims. So in that structure, you've got the Partnership Board. The Partnership Board is responsible for setting the health and social care strategy for our Integrated Care Board. So on that Partnership Board will be a range of people. Some people in this room might be on that board, and Mike is in the process at the moment of looking about what membership looks like there. It's drawn beneath that. It's probably not beneath it, but reporting in and out of that is the Integrated Care Board, which will be chaired by me. That will be a delivery board with executive functions. All the partners around the table there will be the chief execs of those partner organisations. So they will be primary care, our acutes, our local authorities, etc. And we will have the responsibility for delivering the service. But really critically important, you'll see there's 2 boxes underneath. The first one is around our integrated care locality partnerships. And you know we've got 6 of those in BNSSG. That, for me, is the bottom-up approach to health and social care. Up until now, I think we've pretty much had top-down, and I think we need both top-down and bottom-up. And those integrated care partnerships, I've already visited quite a few of them. You can see how that's the opportunity for us to get some quick wins, to do some things that really benefit people's lives in our communities. So there will be that feeding up. And then additionally, I will have 5 committees. And within those 5 committees, you will see I've got people, outcomes performance, primary care commissioning, audit, finance, and the remuneration committee. They will have the responsibility for doing a lot of that board work, because I have said that those board meetings will be confined to 2 hours. I am going to have a huge amount of very senior people there. If I've got them there for more than 2 hours, they'll switch off. As you know, you can't keep people's attention for that time, and they're very busy people. So I've got the first shadow board on Thursday of our integrated care board, and the primary function of that agenda is going to be 2 things. The first one is around relationship building and the type of board that we want to be. So I think that session will be predominantly about the ground rules for us as a board, about the values we espouse. And it was interesting to hear the question around equality, diversity, and inclusion. That's where I've just come from speaking at a conference around that in BNSSG. And that has to be the spine that everything hangs off. That is about our values. That is about the type of leaders that we need in our system. So that is going to be critically important for us going forward. So that's the structure. As I said, we're legislated from the 1st of July. Clinical commissioning groups will cease to exist. It's the last clinical commissioning group governing body meeting today. So from the 1st of July, they won't exist anymore. And those commissioning functions or contracting will come into the Integrated Care Board, which I'll be chairing. So this is the functions of an Integrated Care Board. We've got a responsibility to develop the plan, which meets the health needs of the population. And of course, that will take into account the strategy that's set for us by the Partnership Board. We've got to allocate the resources to deliver the plan. We'll establish the joint working arrangements, and that will be through a principle of one public service, where we can do that. Again, that is not an easy one, because we've all got different governance structures and we've got all different layers of accountability. Just as part of my research, I looked at those people that hold the chief exec of an acute trust to account and got to 75 people and stopped counting. And most of those people can put the chief exec before a court. So you can see how that can sometimes skew people into doing what is asked of them rather than what the right thing is to do for us here. I talked about contracts and agreements and, of course, the NHS People Plan. Okay, so I would just finish off probably, because I think you'll have some questions for me, to say, I think this is the biggest opportunity we have had in many, many years. I'm already seeing a push back into the centre within the NHS, which I don't think has been experienced before from colleagues like myself across the system. I think we've got a number of people who will be chairing our systems who are not just NHS-centric. And actually, we need to galvanise the efforts of everybody across the whole of the system. So whilst I can't answer that question around finances, we're not immediately going to pick stuff up and drop it in a different place. That is absolutely the intention, that we are delivering against those 4 aims. And that is not going to be just continuing to feed money into acute care. It can't be. It's not going to work. So your voice needs to be heard through Care and Support West. You know, that needs to be coming into the system. You know, and I'm more than happy to listen to any sort of comments, questions people have got. So fire away, David.
Yeah, thanks, Jeff. We would normally do Q&A at the end of all 3 speakers, so probably we'll do that if that's okay with you. So Jane, over to you. I dare say you'll introduce yourself, but you're very welcome. Nice to see you here.
Thank you very much for inviting me. My brief today is to talk about home care. And just first of all, a few words about the Home Care Association. So we're a national body across the UK. We're the only association to focus exclusively on care in people's own homes. And together we ensure that home care is valued so that we can all live well at home and flourish in our communities. And we provide practical tools and hands-on support for providers, and also act as a trusted voice to shape home care together. So there's been quite a lot of talk about influencing change and speaking up. That's what I spend a lot of my time trying to do. As far as practical support goes, we have over 100 resources for our members, ranging from things to think about when hiring young people through to recovering debt from local authorities. We run training workshops and events. We have helplines, legal helpline, HR helpline, policy and practice. And we also do DBS checks for providers, not just home care, but anybody. As far as influencing and representation is concerned, we work with a range of different levels. So with central government, Department of Health and Social Care, the HM Treasury, the Department for Levelling Up, and the Home Office. Basically, any department that sort of has something relevant going on. HMRC lately quite a bit. We work with the Local Government Association and DASC, and also quite a lot directly with some local authorities who approach us for assistance. And we work with the regulators across all devolved administrations, increasingly with the media, trying to get our message out to the general public, and working very closely with our partners in the sector, so Care England and National Care Forum and the disabilities organisations and Shared Lives Plus, lots of different organisations involved in care. And on our representation front, there are sort of short-term representation, helping providers in the here and now. So some of the things that we've influenced over the last couple of years have been getting more money out to providers to keep everybody going during COVID. We were instrumental in getting a reversal of vaccination as a condition of deployment in home care, which probably preserved 15 to 20% of the workforce at the time. We've persuaded the Migration Advisory Committee to recommend to the government that care workers are added to the shortage occupation list, and now to advise the government that they need to reduce the cost and complexity of that process. We got free PPE till the end of March 2023. So lots of things that have come about, and often I find myself reminding the government that home care is a thing, because everything is about the NHS and, if you're lucky, care homes. We also were involved in the white paper, lots of different elements of that, and we were really pleased that the rhetoric anyway in the white paper is about keeping people well at home. That's really what, the message that we're putting across, keeping people well at home, keeping us all connected to our communities, active and engaged, giving us choice and control. That helps to improve our health and well-being. That helps to reduce costs for the health and care system. It also keeps people in work. Care itself is a big economic sector. We offer massive employment opportunities opportunities and collectively contribute 50 billion to the economy. So these are all very important messages. Now, as you all know, providers vary a lot in the market, ranging from very small to very large, from predominantly state-funded to predominantly private pay-funded, from generalists to specialists, from startups to mature businesses. And trying to get everyone to agree sometimes can be quite a challenge, but we find that our members all agree about these 5 themes: workforce, financial sustainability, regulation in all of its forms, quality, innovation and best practice, and public perception and public awareness. So these are the themes that we concentrate on. Stephen mentioned earlier demand rising, and we see that from a provider perspective as well. Last year, we commissioned YouGov to do a survey of the public, and what you can see on the left-hand bar is an increase in the green, which indicates that nearly a third of the public, over a third of the public, interviewed reported that they were more likely to choose care at home as a result of the pandemic. And the reason for that was about choice and control. It was about being able to see who you want, when you want, eat what you want, do what you like, in your own home. And in many ways, we've been victims of our own success. So DASC, the Association of Directors of Adult Social Services, have reported a 16% increase in hours of home care commissioned over the last year. But also, the number of hours that they want to commission but can't find anyone to provide has gone up from about 286,000 to over 2 million. So we've got a real issue with unmet need. And this is a problem because although a lot of the national discussion is about hospitals and care homes, collectively in hospitals and care homes, there's only 500,000 people in those at any one time. But there's probably about 15 million people at least that need and receive care in their own home, 13.5 million being supported by informal unpaid carers, probably just under 1 million being paid by paid carers, and about 1.5 million Age UK estimates that need support and aren't receiving it. So if we can do what Stephen said earlier, try and focus on the front end and stop as many people coming through to those many expensive forms of care, that would be awesome. But unfortunately, at the moment, the system is not working in our favour. Currently, everything is focused on the hospitals, it's crisis management, and we need to shift that dial on demand and invest in more community-based services. Now, a lot of people today have said there isn't enough money. I dispute this. I just think the money isn't being spent in the right places. If you look at data on the UK, we're spending about 10% of GDP on health and care. That is comparable with what our neighbours in other countries are doing. We are we've had an increase of about 30% more hospital doctors, but at the same time an 8% reduction in GPs. We're not investing in social care. We're not investing properly in capital, in diagnostics, in beds. We're bottom of the class when it comes to beds per capita, bottom of the class when it comes to MRI scanners, other kinds of CT scanners. We haven't got a chance unless we start doing things differently and putting money in the right places. And look at this. Only 4% of what is spent on the NHS is spent on home care. And everybody moans that there isn't enough home care. Why do you think? You have to be a rocket scientist to see what the problem is here. And I would submit that if the NHS wants to solve its problems, it needs to jointly commission home care, work together with the likes of Stephen, and put some of the money that they got from the health and care levy into supporting social care, which will also help them, because they can't get their waiting list down, they can't address their ambulance waits, they can't get on top of their operations and their clinics unless they keep that flow through the hospitals. And luckily, the NHS is actually realising that supporting people at home is quite a good idea. And there are some new services like Hospital at Home, next year bringing anticipatory care into the frame as well. And early studies have shown that this kind of approach saves money and improves outcomes. So what is there not to like? And technology was mentioned earlier as well. There are numerous gizmos and gadgets. There are smart homes, there's devices to help communication, there's falls monitors, there's even robots all kinds of things, and we have to ask ourselves why this isn't used in a more widespread way. And I think, ultimately the goal, the prize, is the data, because if we have really good data, big data that we can integrate from different sources, we can personalize care and improve outcomes, we can drive quality and safety, we can enable predictive and preventative health strategies and facilitate policy making. One of the common things I hear from the Department of Health and Social Care is, oh, it's so much easier for the NHS to get money because they've got good data. So that would really help us, ultimately saving money or doing things more efficiently, or at least having enough money to support the growing numbers of older and disabled people. And I just wanted to share a bit of an idea that how we could do things in the future, because this is a French study, and they had about 300 people over 75 that were receiving regular home care. The home care workers didn't know anything about their medical conditions. They just recorded what home care workers normally record. Things like, did Mr. Jones get out of bed this morning? Did he make his food? Has he had any visitors? What's his mood like? Does he seem feverish? Does he have swollen legs? All of the normal kind of things that you might record. And this cohort of 300 people were followed over a year, and a third of them ended up in A&E at some point during that year. But when the data scientists took the results, took all of the observations from the home care records and correlated them with the hospital data, they were able to use the data to predict with 70% accuracy admission to A&E 2 weeks before it happened. Now, if you could imagine being able to do that at scale, being able to target the interventions, then we might actually be able to start using our resources more efficiently. But of course, all this depends on having enough workforce, which currently in home care is a bit of a problem. Skills for Care data show the highest ever recorded vacancy rate, 13.5%. And we know the reasons: insecure pay, inadequate pay, layered on that Brexit, COVID policies, and now we've got cost of living. So when we've surveyed our members and asked how many of their care staff are worried about cost of living, regardless of whether they're predominantly private pay or state funded, over 90% are really, really worried about it. And when we've delved a bit further, the two key areas of real concern are fuel costs for driving cars in domiciliary care, and also household energy bills. And we've managed to get a fair bit of national coverage. We even managed to get ITV National News to cover last week the results of our fuel and sick pay surveys, despite Partygate and the Jubilee. So we're up there. Now, David asked me to talk about financial sustainability. We did the mother of all freedom of information survey studies last year. We wrote to 340 public bodies across the United Kingdom, CCGs and local authorities. 312 of them confirmed that they purchase care from independent care providers. We asked them for their lowest fee rates, highest fee rates, average fee rates, how many hours they were commissioning in a given week in April, and also the budget that they had. And the results are not awfully encouraging in that very few were coming anywhere near what we consider to be a minimum price for delivering good quality care. You'll notice that the South West comes out relatively well on this kind of metric, but having been a care provider myself in the South West, there are very particular issues down here because of the rurality, the low population density, not so much in Bristol City, but once you get out to Somerset, Devon, Cornwall, the costs of delivery are much higher. So the amount of money that you need is higher to make it work. And we used all of the data that we collected to calculate what we think the deficit is. And our estimation is that we need about 1.7 billion extra a year to make sure that home care across the whole UK receives at least the minimum amount of funding. In fact, we actually also calculated how much it would cost to give care workers the same wages as Band 3 HCAs in the NHS. and we publish our findings in our minimum home price for home care report. But what you can see is that at national living wage, the fee rate that we believe is needed is around £23.20. If you start having to offer wage rates closer to £12.50 an hour, you need closer to £30 an hour. And a lot of people say, what do you do with all that money? You know, the care workers get half of what you get paid. Where's it all going? And the reason is that all that hourly rate has to cover all of your operating costs as well as your direct staff costs. So if you take national living wage at £9.50 an hour and you add on statutory pension, national insurance, statutory sick pay, holiday pay, average travel time and mileage, that comes to £16.57 before you've even started. We've got some local authorities in this country only offering £15.80. So that doesn't even cover direct staff costs, never mind all of the other operating costs that you have to cover. And to be, you know, to keep people like Debbie happy in CQC, you have to have a registered manager, you have to have a registered location, you have to train your staff, you have to show that you've got enough staff, you have to recruit enough staff, you have to provide training, you have to pay your fees to CQC, which is not insubstantial, you have to have IT and telephony, you have to be insured, all of these different things that you have to cover the costs. I'm not going to, other people have already talked about the policy and funding reform, so I just want to go straight to the problem. That I think, you know, where we stand, we think the fair cost of care is a really good idea in principle. In fact, we've been lobbying it for ages. Like, you know, who would not think it's a good idea for local authorities to understand the costs of care delivery and to pay a fair price for it, of course, and to minimise the gap between, you know, state-funded and private pay. The problem we've got is that the Treasury at the moment hasn't allocated enough funding. So the Competition and Markets Authority estimated that we need about £1 billion extra to cover the gap for care homes. We're saying about 1.7 billion a year for home care. So that's nearly 3 billion extra a year, but actually what they've given us is 1.4 billion over 3 years. So we've got at least, you know, at least 10 times too little funding, probably more. And that's why these cost of care exercises are so important. Yes, you're not going to get your fee rates up to the right level straight away, but unless we give our data to the government through our partners in the local authorities, unless we show them how much it costs, we haven't got a hope in hell of ever in the future getting more money. So I entreat you all. I know it's a real pain. I know it's time consuming, but please, please work with your local authorities and put in your data on your care costs. There are dangers with it. It risks baking in poor practice if you only talk about what your costs are today, not what you think they need to be. But that, you know, I'm not quite sure what stance Bristol's taking on that. I think there's quite a lot of worries here that if we don't get the fee rates to the right level, we risk destabilising the market. In home care, actually, Section 18.3 of the Care Act has been in force since 2015. I don't know how much it's used in Bristol. In some places, it's mostly been used up to now for people discharged from hospital, initially who had, say, 6 weeks of NHS funding and then needed ongoing care. And at that point, the assessments were done and there was conversations about sourcing care at local authority rates. But I think the public are going to become much more aware that this legislation is a thing because everyone's going to have assessments to start the care cap clock ticking. And at that point, they're going to realise that they potentially can get care at local authority rates. And of course, if everyone buys care at local authority rates and they don't go up enough, half of you are going to go out of business, which isn't really going to help anyone. So we're calling in the short term for extra money for fuel allowance. We still think maybe now Boris is on the back foot, we might have a bit of a chance. Reinstate COVID funding for sick pay because a lot of home care workers are not receiving sick pay when they're having to isolate for COVID. And just invest properly in home care so that we can make it sustainable. We also think that the practices that councils have adopted of purchasing home care by the minute or the hour, that purchase for task and time rather than outcome is mitigating against using technology solutions. It's mitigating against retention and recruitment of the workforce. So we need to get to a point where we can avoid having to do that. So just to summarise, demand for home care is rising. We should all be pleased about that. And actually delivery has risen too by quite a lot. complexity of need is increasing. We need to invest, though, to improve outcomes. We need to invest in the workforce. We need to invest in innovation and technology, and most importantly, invest to ensure improved commissioning and improved sustainability of care services. So I'm going to stop there. Thank you.
Thank you, Jane. You've probably used up the entire pad to be putting down questions for both Jane and Jeff. But the person who needs to be made happy is next, apparently. So, Debbie, do come and join. And after this, after Debbie's done her session, there'll be another round table chance for you to have discussions. But Debbie, very nice to welcome you.
Thank you very much, and thank you for having me along again. And this time I'm actually coming with a very different role, although I'm hoping I can answer some of your more general queries too, because I'm now the Director for people with learning disability and autistic people at CQC, and that is a real privilege, but also it's a real challenge for me. And one of the things that's been brilliant about the last year when I have been doing this role is that I have actually not been trying to please people. I have been very much doing the opposite. I've been raising issues and I've been shouting loudly because people with a learning disability are not getting the services that they should across our health and care system, and it's time for that to change. And picking up on the point that Jane just raised, I just think it's so important that we start to think about some of these things differently. It's a time to think about difference and how to do things so that we just don't get the same old solutions that we've had over the past years, because that's why we're in a situation now where there isn't the right resources and there aren't the right services available for people. If people continue to not get preventative services, they will continue to go into hospital. They will continue to have the problems that they're having there. And for people with a learning disability, when they come out of hospital, they then have to catch up 4 or 5 years, perhaps, of damage that has happened to people. It is not always the right solution. I am going to give you a bit of a more general background to what's going on in CQC. I'll come back then again to the learning disability issues and then finish off with the local authority and ICS challenges that are ahead of us. Our role and purpose hasn't changed, but our organisation is changing. We've got a new strategy that was launched last year with 5 key areas: smart regulation, people and communities, safety through learning, actually it's 4, and accelerating improvement. But what I wanted to talk about today is that what we're doing is we're changing the way that we work, both in terms of the organisation of CQC. So I now work in something called regulatory leadership, which is separate from operations. So we have a group of people who are directing the way that CQC will be addressing the issues that are so important across the whole of health and social care and bringing them together, looking at pathways and integration. And then we have our operations and a restructuring into the regions so that people will be, and we're looking at how that's going to work. What are the roles that we really need our inspectors, our assessors, and others to do to make sure that regulation is the best it can possibly be? We do, though, know that people's experience in care is the most important source of evidence that we can get. And what we're trying to do is turn around our systems a little bit so that people using services, their families, friends and advocates are the people who are telling us how well the care is being provided, what is good about what's happening to them. People's experiences is going to be one of the 6 evidence categories in our assessment process. It will be required in lots of different settings, but of course it will be required in both residential and home care, whether that be for older people or people with learning disabilities. And I'm also really keen that we make sure we hear all of the voices, so not just those people who can talk to us and who can tell us what their care is like, but that lady with dementia who's in the room at the back that's often can't reach her core bell and it can't be heard. That person who is in a wheelchair, who actually can't get out of the room but can hear shouting going on in the corridor. That person with a learning disability who is only able to speak to us if we are there with them, using either sign language or perhaps talking pictures. So how's this going to work? How's this all going to change? Well, we're going to have a single assessment framework. So right across the whole of health and social care, we will have this one framework. We're going to keep our 5 key questions. But what we're trying to do is to really change the way that we think about quality. So we will start with I statements, and those have been developed with TLAP, Think Local Act Personal, and they're all about what people expect to receive from their care. So there will be I statements that we base our judgments on. Then there'll be quality statements, and those quality statements are we statements. So they're what the providers, what you, and what the system will deliver for people. Those are the things that we're going to assess against. Currently, do you know, we've got 335 Cllrs. It's just far too many. It's far too many, and it makes it far too complicated for people to really understand what it is they need to be achieving and driving against. So we're going to get rid of that, and what we're moving to is 6 categories of evidence. People's experience, feedback from staff and leaders, feedback from partners, observations, processes, procedures and outcomes. And then performance data and information specific to those services. So we're changing into this process, going through this at the moment. Some of you hopefully will have been involved in the conversations we're having, because there are plenty of opportunities. Go to our website, get involved in the conversations, help us to shape this and to get it right. Because it's really important, isn't it? Because at the end of the day, what we want to know is, what is it like for people using a hospital? What is it like for people living in a care home? What kind of life do people with a learning disability have in that service? So I'm now going to bring me back again to the work that I've been doing this year. And I'm not going to dwell on this because you all know this. You all know those awful stories that we've had to listen to again and again and again over the years. Professor Glynis Murphy, after Walton Hall, helped CQC to look at what we should be doing and how we should be doing things differently. It led to a whole piece of work in CQC to talk about closed cultures. And I think probably a couple of years ago, I talked a little bit about this to you before. But that's now really developed, and we're really starting to build up both systems to tell us when there might be a closed culture, because do you know what? I most worry about those quiet services, those silent services that we hear very little about, where we don't really know what's going on. Those are a big worry for me. But also those services where we start to get indications about the culture and what might not be working well. Then we did our out-of-sight work. And we've just reported again on the follow-up of that, and that was so disappointing. So few of those recommendations have been met. Things haven't moved fast enough. Too many people are still in hospital for too long, and too many people are restrained and have restrictive practice on them on a regular basis. It's just really disappointing that things did not move fast enough. So the government's delivery board has got a lot to live up to. The action plan should be out soon. There's a lot of work being done on resources, but it's got to move faster, and it really has got to get people thinking in a different way. So not thinking about services, but thinking about people. What is it that people need? This is about people's lives. It's not about a few days in a hospital or a few hours in a GP surgery. This is about people's lives, and we have to really make sure that the whole of their lives is supported in the right way. So my work has been really around looking at what do we do to change this? How do we get that different focus? Now, I know earlier we had some quotes from Alternative Futures. But if I said to you, our goal is to see people with learning disabilities in the mainstream of life, living in ordinary houses and ordinary streets, with the same range of choices as any citizen, and mixing as equals with other members of their own community, when do you think that might have been said? 1988, that one, King's Fund. And we're still not there. We're still going around this same circle. We're still trying to create mini institutions in the community. I had a discussion last week with people who wanted to build a new hospital with 3 big 10-bed units. It's not acceptable. We know that what works is, and what people want, is to live in settings where they're choosing who they live with, where they're choosing where they live, in the communities that they want to be in, but also where people are with a group of people that they can live with and they can learn the skills they need to develop a full life. So, right support, right care, right culture, I come back to this again every time. That's the basis of what we're doing. And you know what? I'm not making any apologies about this, because we actually are trying to shape the market. We are trying to make a difference, and we will not register services that don't meet that standard. I have a lot of discussions with commissioners where they start to talk to me about, oh, it's not value for money, we need to have at least 15 people together, we can only do it in this building on this site. I don't make any apologies. That won't happen, because that actually isn't value for money, because it is about people's lives and they will not benefit. They will not be able to achieve the independence of life that they need in those settings. Okay, so what are we doing about it? Well, so as I've just said, we are making sure that we will only register those services that do meet the standards that we've set. And right support, right care, right culture isn't something I wrote or made up. It's from research, it's from practice, it's from what people have told us is right, it's from the NICE standard, it's from a whole different set of guidance that's been developed over the years that actually works, and what people have said they want to live in that way. So we need to make sure that it's properly understood by everybody, that's planners, commissioners, that people don't start building services, that don't start planning for services before they've talked to us and they've read right support, right care, right culture. Don't waste money on something that's never going to be registered. So that really is an important message. You know, talk to us. We've got a new team now that only registers services for people with a learning disability. Talk to them. Talk to them about what that might look like, how those services should be. And we are worried because people are seeing that there's a gap in the market. And whilst I know that most of you are really good providers, and there are some people who are saying, oh, hang on a minute, maybe I could do that. Maybe I could do some care for people with learning disabilities. Don't know anything about it, but I know that it pays a bit more money than what I'm doing at the moment. That's not okay. It's a skilled task. It's skilled work. It really does need people who have that knowledge, that experience, and you just can't jump between different areas, just as you wouldn't expect somebody to move from working with people with learning disability to providing dementia care. It needs to be done by people who have the right approach and the right skills. Supported living has become a little bit of a loophole for people in that some people will register as personal care, then decide, oh, actually, I'm going to be supported living. Go out and buy a big old care home, do it up into a load of flats, and there we are, we're off. And they let us know afterwards. Not going to be acceptable anymore. We're going to start to impose conditions on providers where we think that might happen. And when people put themselves forward to provide personal care, then that's great. We will assess their ability to do that. If they put themselves forward for supported living, we will assess their ability to do that, but not be able to move between each of them. We're also looking at how we make sure that the right people are protected by our legislation. And there's going to be a bit of a review of the regulations shortly. And do you know that if somebody comes out of hospital who perhaps is an autistic person who has really complex sensory needs, complex communication, that they could move into a supported living service or a care home, and we might not be able to actually even look at their care because they don't receive personal care. And they don't receive the kind of personal care or prompting and supervision that is in the law. We cannot therefore regulate it. We can't regulate some of the settings where people perhaps are at their most vulnerable and most likely to be subject to restrictive practice. So again, we've got to change some of those things around. We're looking at possibly a change to having a supported living category under our regulated activities, which might make things a bit more straightforward. Okay, we've also, sorry, I did mention on there Supported Living Improvement Alliance. We also want things, obviously, to get better. And I don't know whether any of you are involved, but we've got a Supported Living Improvement Coalition that's running now. It's led by people with lived experience and their families, and has a whole range of different people from local authorities, people who run services, people who live in services, all talking about what supported living really should be like and what it's like for them. We'll be publishing something from that later on in the year. But it's really exciting work, and lots of people are coming forward with lots of great ideas about how they've worked really hard to make supported living the best it can possibly be. And when it's right, it's just fantastic for people, because it really is about their lives and their lives being able to be supported to lead it in the best possible way. Our inspection process has also been changing, and some of this is the kind of things that will carry through into our new ways of working. So we have teams of the right people. People who inspect adult social care have been going into hospitals for people with a learning disability and vice versa. We've been really making sure that we have experts by experience whenever we possibly can, and other people like pharmacists to check what's going on in those services as that service needs it. So making sure the team is right for that particular location. Observation is absolutely at the heart of the process. What is it like for somebody to live here? What does it feel like? What is it like when somebody wakes up in the morning? What is it like on a Friday night? What's it like on a Sunday morning when you're in this service? Using new tools, we have a quality of life tool that's new on our website. We've got Talking Mats pilot that's being worked through at the moment, a different way of getting information from people that's been really useful to talk to people that we've not been able to talk to before when we go out to services. And our reports are changing, and they will reflect what is it like for people living in that service. But whilst we're finding many really good services, and I've seen some great reports recently where services have gone up to outstanding over the last few months, what we have to make sure is that we're taking the right action when we do find things wrong. There are some things that are just so obvious and give us so much indication of what a service is like. And I want to say to you, words really matter. Written, spoken, the words that your staff use to describe things, the words that you see written in the daily log. What does that tell you about the culture of your service? How do you check quality? Will you see what we see when we go out to look at inspection? Are your eyes wide open? Do you hear the way people are talked about? I was in a service a couple of weeks ago, and somebody said to the inspector, I'm not going to say anything bad about this home, this person with learning disability, because I won't be the manager's favourite anymore. What does that tell you about the whole of that service? What indication does that give you about the way that's run? I had a member of staff showing one of my staff how to do a headlock the other day. They didn't even know that that wasn't something they should do. You know? It sounds astonishing, but it's true. And I think that's one of the things that when you're checking, when you're thinking, think about, how do I really know what it's like when I'm not here? How am I really able to pick up on those clues and cues? Thinking always about respect, citizenship, and control. Who's got the power within the service? And one of the things that quite a lot of people have been talking to me, people with lived experience, about recently, is about how do you move from having the power to sharing the power to actually bringing the power that's within each person out, to enable them to actually make the decisions about their lives. So, when we find things aren't right, we have been taking the right action. We've done an emergency closure of a hospital, first time ever. Lots of other work going on. We've had some situations where we have had to take urgent action very recently in services for people with a learning disability. And often it is where the local commissioners don't even know that service exists, because it's people who've been placed from out of area. Nobody's been to see them. All through COVID, nobody's been in the service at all. And there are some really dreadful things. Do you know, I find it quite shocking that often, even in a care home, people don't understand they're putting people into seclusion or segregation. They don't understand that what they're doing is restrictive practice. And the overuse of restrictive practices is at best bad practice and often really is unlawful. We know there's a pressure on places to live. We know that people aren't often given the right choices and people are fitted into placements and available spaces. And what we also see, and what we've read in the recent safeguarding adult reviews and the leader death reports, people with a learning disability are still dying 10 years earlier than other people. There is a real shocking lack of ambition about what people can achieve in their lives. These aren't necessarily things that cost money. That lack of ambition is about how you work with somebody to move towards the goals that we all strive for in our own lives. This is about people's lives, not a service. It's also really important, and that hasn't moved on, there we go, that we think about the whole of people's lives. And that means that making sure that people are able to live full lives in the community, that they've got the support, the intervention, the healthcare, the dental care, the access and the adjustments that are needed to live that life. So we've just done a piece of work that we'll be reporting in the autumn, where we have followed groups of people with learning disabilities in their journeys through acute hospital. It's not going to be a positive read. It's not going to tell us a good story about how well people actually's needs are met when they go into hospital. We're doing another piece of work which is about autistic people's access to GPs and dentists. There's some great stuff coming out, but a lot of the things that people are telling us they're doing that are good, autistic people are saying, well, that wouldn't work for me. And I think we sometimes get into this, oh, this is going to be the right thing to do for autistic people. A great story. A young man went into the GP, and they were so proud. They were really, really pleased because we've got you a really quiet waiting room here. We've taken all the sensory stuff off the walls so that you can sit here quietly and wait, and you'll be on your own. It should all be fine. In the corner was a fridge that buzzed constantly and went on and off, clicked on and off, and he couldn't bear it, and he had to leave the GP surgery. It's about thinking about people, about individuals, what they need, and how to respond to those things. So I think, at this point, I just want to say that actually ICSs have got a massive responsibility here going forward. They need to know the population needs. They need to assess what's needed for people now. Some people maybe in hospital need to come back. Some people may be coming up to or experiencing crisis. How are they going to be served within the community? How are we going to do something that stops this drip of people into hospital where they stay for 4 or 5 years and then it's so much more difficult for them to come back? We need to intervene early. We need to make sure that people have the care they need at the right possible time. We need to get it right in the community for people. So just to finish off, and I'm not going to say much about this because we've covered it, I think, a couple of times already today. So the new Health and Care Act, bringing a position for CQC to be able to not only talk about the provision of care, but also about how it's organised. So we now will have the responsibility to assess both performance and the delivery of care. So it's the responsibility of the system to get the right support and the right services, and the responsibility of you as providers to deliver it. And these new duties that come through, our approach will be very much on looking at integrated care systems, leadership, integration, quality and safety, and the 4 themes for the local authority: how they work with people, how the local authority provides support, how the local authority ensures safety, and that leadership and workforce. And I'm going to finish there, but I did just want to say that the question earlier about whether we should reduce our standards because the finances are so difficult at the moment, actually it's a really, really interesting question, because do you know what? People use the quality of care as a reason for not needing to provide additional resources. Well, they're all good. 85% of services are good. That means they're managing, they're doing well. And I absolutely can tell you now there won't be a reduction in standards, because it's absolutely right that the quality of care and what good looks like will remain the same. It won't be reducing. So I hope that's given you a bit of a whistle-stop tour of some of the things that are on my mind at the moment, and thank you for listening so well.
Thank you, Debbie. Well, now then, your roundtable discussions, a bit of a challenge, I'd say. So you're just going to deal with integration, briefly to start with, from Jeff. You're then going to talk about service delivery and from Jane, and that whole raft of stuff. I was really interested, Jane, that you challenged the notion that there isn't money, and I so agree with you. It's about where it's being spent. And I think that's a message both for central government and probably for local government too. And yes, it's very, very hard, but there we are. And then just to finish off with a little bit of regulation. Thank you, Debbie, for that. So roundtable discussions for 10 minutes or so, and then we'll come back with questions and points that anybody wants to make to either of the three speakers in our last session. Thank you. Okay, let's see if we can round this off. So questions either for Jeff, Jane, or Debbie? Anything? Over here.
Hi, thank you. Some great presentations there again. Thank you for the speakers again. Probably a question for Jeff, but open to all of them. I've heard you speak now twice, I think, and I've been encouraged by the points you put across and how you see it working. Realistically, though, I just want to see, in terms of timescales, when do you see us actually seeing a difference on the ground, if you like, in terms of the plans you've got?
Well, I think the difference will be seen immediately in the ICPs, and I think that's where we should see it, when we start to see the localised partnerships identifying things that can happen. But we've got our first shadow board on Thursday. I think there's two, you hear me talk about that, or some of that. I think there's two key things in there. The one is about, you know, everybody says we want to do things collaboratively, but the integrated care system is not the CCG, in that the CCG was a separate organisation that commissioned services. You are all the integrated care system. I just coordinate it together with a team of people. And I think that is it's not a subtle difference, that's a major difference to the way we have to approach the way we deliver services. So this is the conversation I had with Shane Devlin, who's the chief executive. That meeting now on Thursday, he's already done some of this work with the chief execs from all your organisations, and we will identify 2 or 3 key priorities, and Home First. So it's really interesting to talk about, you know, how we get that flow through. Home First undoubtedly will be one of them, about how we make sure that we align services and funding to the right place. Now, there's going to be some really difficult conversations, but that's why I want to start on Thursday with thrashing out the way we want to work, our ground rules, the type of people we are, so that we can then go back in and challenge without being rude. But, you know, I'm in a very fortunate position in that I don't have to work. I've moved over from an acute trust into this role because I think it's so important. And if it doesn't do those things, then, you know, it's not a job for me, but I will give it 100%. And I think you have to see some quick wins. If you don't see some quick wins in a very short period of time, then, you know, it's all going to wither on the vine. So, you know, I do think that's important.
Jeff, whilst you're still on your feet, you and I have had conversations before about this. Getting social care at the local partnership tables is still proving difficult. Right now, we have one in Bristol South, and we have conversations going on about maybe 1 or 2 others. What do we need to do differently to create a context in which we are actually sitting at the tables rather than wondering about how we can get to sit at the table?
So, David, I know we talked about this before, but, you know, I think in the localised partnerships, the 6 that we've got in BNSSG, and also in the partnership board, making sure that voice is there is critical. And so if there's a blockage towards that, so, you know, you've got Steve here with and you know in Bristol you're involved in the one that he's chairing. But if you're not involved in the others, just tell me what those blockages are, because I will make sure that we go back in and look at why Care Support West are not involved in it. You know, you're going to have a critical voice in there, aren't you? And you know, I've talked about this before. We have to start this from a perspective of inclusivity, not exclusivity. Otherwise, we won't bring people with us. But to do that, it means that our boards and our groups are going to be bigger at the start. And then I think as we build confidence and we build trust, we can whittle that down a bit. But I do know our integrated care board is going to be one of the biggest in the country. And we get to an optimum size where if there's too many people there, we don't get the business done. But, you know, David, that offer is back there for me, which is contact me if you're not breaking through, and I'll make sure that I grease the wheels a little bit on that.
Okay, thanks very much, Jeff. Other questions either for Jeff or up there? Do you want to go? Thank you.
Hi, good afternoon. It's a question about the registration. A lot of the innovation that's going to come with the IC, or the opportunities that come with the ICS, is going to come from the private sector. We're already encouraged to be imaginative, use innovation, change our services to meet what's out there. Could you offer any words of reassurance to a provider that might want to change your service, following the rather restrictive comments you made about us having to register a service again? Probably, so mostly aimed at Debbie, I'm afraid. Thank you.
So the comments I made are about making sure that people have the right skills to do the right job. And what it would mean if we put a condition on a provider's registration wouldn't mean that they couldn't come back to us and say, this is what we want to do. And we would then look at it and assess that application against right support, right care, right culture. So it's about making sure the model of care is right, not about restricting people from being able to do something different. And innovation is certainly one of the things that we're really keen to see. And we want services to be thinking, actually, how do we do what I started right at the beginning talking about? How do we make sure that the outcomes for people are right from whatever that service is, whether it be home care, whether it be a residential service, or whether it be a supported living service? And that is what is central to it. And it all depends, therefore, on what the person who is coming forward with that application is able to say about the way that they're going to run and organise that service. And in our new way of working, we're going to make sure that that's the first point of our assessment process on the quality of that service. So it will be a much more seamless run through from your application. This is what you've said, this is what you're going to do. We then start to assess that as it goes with information being gathered to say, are you meeting those things that you've said you'll be able to do? Are you actually offering the service that you want to? And then we come into the inspection part and the rating. So it starts with registration and moves all the way through, but it's all about getting the right people doing offering the right services.
So what's the sort of timescale on that then? How far in advance of opening would you want to hear from us then, in terms of the registration? Because we've had experience where you weren't really interested until we'd opened.
Yeah,
often.
so that has changed, and particularly for the people, for services, people with a learning disability, where we have right support, right care, right culture, which is much more clear about what the model of care that we expect. So it now says on our website, please talk to us first. There's an extra form that you can fill in to start to think about it, and we want to have those conversations, so please do contact us. If you're having a problem contacting us, then give me a shout, because you shouldn't be now. That's really meant to have changed, and it should be much easier to have that conversation. Okay.
Okay, further questions? There was a couple of hands up there. Holly, thank you.
Thank you. My question is probably directed not just to the last speakers, but possibly Stephen and Helen can also interject. Part of sustainability would be retention, and as we know in social care, that's a big challenge, and I can imagine with the economic crisis, it's going to get worse. And also, as we know, social care has such a bad rep. You know, there's been so much negative out there about social care, and a lot of care homes have come under fire during COVID and in very difficult times. But what's been put out there is negative things. And I think, you know, what I would want to understand is where and how can local authority, local government, and possibly CQC help providers in making social care better publicised to help with retention. And there was talk about growing our own workforce, but I don't think providers can do that on their own without the help of local authority and local government.
like to answer that?
Well, probably all of us, but actually, Jeff, I'm sure, because this is about more integrated care and those opportunities to have a career in social care where you can actually work across organisations. And I, you know, I am a living example of someone who started working in the care sector that has moved on. So it is a career, and it should be a career. We need to work together. We also provide our own services within the council, so we're in the same position. We want to retain the staff that we have and allow those career opportunities for people. So let's work together on how we do that. We've got Proud to Care here, helping us to recruit and retain staff. We've got to develop those opportunities so that people can, you know, achieve those qualifications, work across the sector, go into management roles and make it a profession that's understood, because it is a really misunderstood profession. I totally agree, and it's down to us to change the profile of the working in social care.
So very quickly on that one, you know, the whole essence of integrated care is about moving from competition to collaboration. And we've competed for workforce, and we continue to do so. It's a nonsense, isn't it? It's our biggest single challenge is workforce. You know, and when we're going overseas to recruit, well, shouldn't we be building and supporting people within our own communities to work within our health and social care? Of course we should. So one of those things I talked about was the committee. Jaya Chakrabarti, who's going to chair the People Committee for us, that will be one thing that she will be looking at, is around workforce, recruitment and retention, and about how we look at this holistically across the whole of the system. But even within our acutes, we've got different pay scales, different attracting people in different ways. It's madness, isn't it? You know, the public see us as health and social care. They don't see us as a load of separate organisations who should be competing with each other. And if we do, all we end up doing is doing a disservice to people. And I think you're absolutely right. Social care perhaps becomes the least attractive role because other offers in the system are there. So yeah, pushing an open door on that one, and that will feature within the People Committee.
Yeah, Jane.
Hi, yeah, I think you're absolutely right. It's definitely a team effort. But back to what Mei-Ling said earlier, we can also do quite a lot ourselves as providers. If you look on our Home Care Association LinkedIn page yesterday, we posted a video of a home care worker talking about what a brilliant job it is and how much she loves doing what she does. And quite a lot of recruitment is very local. So I think the more all of you pump out this kind of stuff, and with smartphones, you know, TikTok videos, all that kind of thing, it's so much easier now. So I agree that there needs to be help at a system level. Longer term, I remain the eternal optimist. You see, in the future, Amazon warehouses and all kinds of places are going to be replaced by robots. We're only going to have a limited ability to replace care with robots. It will happen to an extent. So I think in the future, lots of people are going to be flocking to us looking for work.
Well, there's a really good thing to be going home with. Holly, up there.
Yeah, so I just want to echo what the last speaker has said in terms of being passionate about jobs, and take this opportunity to draw your attention to a technological development which we have here across BNSSG called Connecting Care. We have got a stand here. If you meet two criteria around IG and technology, this is at the moment free for care homes to get access to information from different parts of health and social care. We've been working collaboratively for the last 9 years, and it is really a jewel in our crown. We're way ahead of lots of other parts of the country, and we really want to help support the amazing work that you're all doing, and also the work that's going to be done by the ICSs. So shameless plug, but also really helpful technology. So please do come to our stand. Thank you.
Thank you for that. Let me just wave in the air also the Digital Security Network little leaflet that you saw on your table. Care and Support West has been managing this project for quite some time, and Karen Holly, is somewhere here today, and it fits exactly with what you've just said in Care Connecting Care. So have a look at the leaflet, get in touch with Karen. And whilst I'm doing that, I can also talk to you about the Workforce Development Fund. Get in touch with Karen in relation to that. This is about you being able to access funds to partially fund training for your staff. Another Care and Support West little goodie there for you. And then finally, this is the Registered Managers Network, a little leaflet also on your table. Here's the bloke who does it, Mick, the man taking photographs. Get in touch with him if you haven't linked up to the Registered Managers Network yet. So that's just a little advertising going on. We should probably close shortly. Are there any there's a last question from Mick himself.
Back in sort of July 2021, there was a report done by Unfair to Care, where they looked at the role of a support worker and they sort of benchmarked that across other professions and other roles. And what they found, that in terms of the sort of complexity and the accountability of the role of support worker, equivalent jobs in other sectors were sort of getting paid £7,000 more. I just wondered, in all of this conversation, how long we should continue to be unfair to care?
People will want to race to the platform to answer that, I guess. Jane, thank you.
You're absolutely right, and certainly both the Association of Directors of Adult Social Services and us, we've been lobbying for care workers to be paid equivalent pay to HCAs in the NHS. Now, the hourly rate is only one part of that. Obviously, NHS staff get other terms and conditions that are very favourable, so probably the hourly rate needs to be even higher than, you know, the equivalent £11.14, probably needs to be closer to 15. Really. What we need to, I think where we need to get to is a pay, a wage that allows somebody to support a family, you know, rather than it being a sort of, you know, secondary thing that you do, you know, then we will start to really see a change. And you know, what we keep saying, I co-chair the workforce advisory group at the Department of Health and Social Care, and we're always on at them about, it's all very well having knowledge and skills frameworks, and that's a great idea, but if you haven't got enough money to give the salary differentials, you're not going to create career pathways either. So that's another challenge that we've got to keep lobbying for that funding.
Thanks for that, Jane. I'm going to close off on the questions, but just on that point that we've just been talking about there, you'll find in this report, can't remember which page it is now, a compare and contrast table of healthcare wages and social care wages and a suggested level for both frontline workers but also managers. So do take this away with you or go on the website to dig it out from Care and Support West website. I think we'll probably close off now, and I'm going to invite Diane, the chair of Care and Support West, to close us off. Diane, please.
Thanks, David, and thank you all for coming. I think you'll all agree it's been a great sort of morning, early afternoon session. It's been really nice to see so many people back in here again it's my first live conference for at least a couple of years now. So some great thoughts. I think looking back at the title of Fixing Social Care, I'm not sure we quite fixed it. We certainly talked a lot about the challenges, but thankfully as well, we've also talked about opportunities. And I think locally, certainly, there are some opportunities. Sorry, can you hear me? Yeah. There are a lot of opportunities, and I think we've touched upon them, especially this afternoon. And I hope you all take away some of those things. And I do hope that when we see each other, maybe next year or the year after, we will have seen some of these things develop into actual things that make a difference on the ground to the people that we care and support for. Quick final thank yous then. Thank you all for coming. Appreciate you're really, really busy. So to see so many people here, I know we've got a few people who obviously haven't been able to turn up for obvious reasons. But it's really, really good I think this is the largest conference we've had. Obviously, it's a great topic, some great speakers. Thank you all for, especially sort of the nationals. Well, you're all reasonably national speakers now, and I probably want to take this opportunity to thank you all for your support through the pandemic and raising the profile of social care. And thank you, a huge thank you for Ashton Gate, the exhibitors, and the training hub. Without the training hub and the exhibitors today, we wouldn't have been able to fund this. And then finally, most importantly, thank you, David. There's a huge amount of work that goes in today. I know you've got a good team behind you, but a lot of it does fall on your shoulders. So a massive thank you to you. And I'll finish now at roughly 2:30, which is what was on the agenda. So thank you all, and take care. Cheers.